evening.
Akka, good evening. Welcome,
We are
welcome
live
all.
now, ma'am.
Yes.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on emergency obstetrics, organized by Amogs Emergency Obstetrics Committee with Tnfog, Madurai, Trichy, and Dindigal OBGYN Society, under the guidance of Dr. Sneha ma'am. So let us start the webinar with lamp lighting and God's blessing.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
It's my privilege to introduce the coordinator of today's webinar, Dr. Priya Kannappan ma'am. Ma'am is the consultant OBGYN fertility specialist at Dr. Mehta's Hospital, Chennai, and executive committee member of Oxy Chennai. And ma'am has received many awards and best resident award from Manipal University. Ma'am has done fellowship in ultrasound. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahati. So it's my great pleasure to invite all of you to the webinar on emergency obstetrics, along with Amogs and the Tnfog, particularly the Trichy Society, the Madurai Society, and the Dindigal Society. So thank you. So it is my pleasure to invite Dr. Madam Sneha Madam. Can we have the CV, please? Madam, I think, she's very well known among everybody in India. So most of us will know her. She is the International MS Signature Award for Phenomenal Leadership in 2020, Asia GCC Award 2021. She has received the Dr. S.N. Malhotra Individual National Award for the Outstanding World Rural Obstetrics 2008, Durusha's Distinguished Community Service National Award 2022. Individual Award Championship for Foxy Award for 2 consecutive years of 2020 and 2021, and Dira Award for 2022. And also Anandibai Joshi State Award of the Government of Maharashtra, Lokmat Healthcare Excellence Award 2020, 300 plus talks, 10 plus keynote addresses, orations, moderated more than 100 panels, 30 plus chapters and articles in national publications. Madam is the Foxy Breast Committee Chairperson 2019-21. She has been the GCM ICOG 21-22, National Adolescent Trainer, WHO FPAS Certified, National Expert in UNICEF, Peer Reviewer of Jogi, Amogs Chairperson for the Medical Disorder Committee 22-24, Amogs Chairperson of Emergency Obstetrics 24-26, Mission Pink Health Welfare and Convener for PCPNDT Act, SAFOG Working Group Member in Breastfeeding, Founder President ISOPAP. Madam is the President of YOX 2007-9, Clinical Secretary of YOX 2003, Life Member in all the societies. Welcome to you, Madam.
Thank you so much, Dr. Priya, for that generous introduction. A very good evening to one and all, respected seniors and dear friends, fellow Foxians. A very good afternoon to all of you and a warm welcome to you. My respect and regards to our chief guest for today's program, Dr. P.K. Shah sir, and of course, Madam Usha, guest of honor. Madam Ramani Devi, the president of TNFOG, Dr. Revati Janaki Raman, the immediate past president of TNFOG, and of course we have Dr. N.K. Mahalakshmi, president of Madurai Society, Dr. S. Padma, the secretary, whom I have a pleasure to talking to them recently. Dr. M. Tamil Selvi, president of Trichy, and Dr. Uma Velmurugan, secretary of Trichy. Dr. J. Amala Devi and Dr. Selvarani, the President and Secretary of Dindigal Societies. And of course, we do have the esteemed, very learned panelists, Dr. Professor Dilshad, Dr. Pravada Vardini, Dr. Minambal, Dr. Lalita, dear Madam Amala Devi and Selvarani, again as panelists, and of course, my right and left, Dr. B. Kalpana and Priya Kannappan. Myself, Dr. Sneha Buyar, along with the President of Amogs, Dr. Kiran Kurtakurti, Secretary Dr. Bipin Pandit, Dr. Rajendra Singh Pardesi, sir, as immediate past president, the entire team of Amogs office bearers, All of us welcome you for this program, and I thank the entire team of Tnfog with special regards to Madam Ramani Devi for this collaboration. I'm thankful to all the members of Madurai, Trichy, and Dindigul societies. The topics chosen today are antepartum hemorrhage and peripartum cardiomyopathy. I'm sure very needful topics, which the cases which we are, facing in day-to-day practice, and of course the panel discussion on labor emergencies. A less chosen one, I would say. The main aim is to reduce maternal as well as perinatal mortality as well as morbidity. So I welcome all of you for this webinar, and it is my privilege and pride to introduce my mentor, respected Dr. P.K. Shah, sir. Sir, all of you know, I mean, the slide, though it is only one slide, you can't count his CV in one slide. I just say that sir has almost been the president of all the organizations you can see here, but past president of FOXI and past dean of Indian College of Medical Ultrasound, and of course, so many organizations. I would say, sir is my mentor, and of course, he was an advisor for Breast Committee. We would like to listen to your precious words of guidance and blessings, sir. Over to you.
Thank you very much, Sneha, for your kind words. And it's a great pleasure to be a part of this webinar on emergency obstetrics, organized by Chairperson Dr. Sneha Buyar, who is the chairperson of this obstetric emergency committee of AOFOG. I thank all the office bearers of AOFOG, especially Dr. Kiran Purtukoti, Dr. Bipin Pandit, and Dr. Rajendra Singh Pardesi. Also, it's so nice to see two great speakers from South, Dr. Revati Janakiraman and Dr. Ramani Devi, both, whom I know personally so well for last so many years. Superb academicians and very good teachers. And they're going to cover antepartum hemorrhage and peripartum cardiomyopathy. Again, two very important subjects, which probably the cardiomyopathy is one subject which nobody wants to read or remember. So I think this is going to be a very, very important webinar. Not only that, but in panel, Sneha is going to cover all the labor emergencies. And I'm sure she's going to cover all those cases which are going to be solved by all superb members of 3 societies from Tamil Nadu Federation of Obstetrics and Gynecology, that is Madurai, Dindigul, and Trichy. And also I see involvement of presidents and secretaries of these 3 societies. I think this is something great. This is how one should have the webinars, involving almost everyone possible from different societies, because they also feel that they are part of FOXI and Amogs, obviously. So without much ado, I think I'll thank Sneha and wish her, Dr. Ramani Devi, all the very best for upcoming elections of FOXI. All the best and 100% success for you too. Thank you very much.
Sir.
Thank you, sir. Thank you.
Thank you so much, sir. Thank you so much for your blessings always. And with this, may I request Sahiti to display the CV of Madam E.S. Usha. And Madam is the chief guest. Madam is the guest of honor for today's program. So, and of course, Dr. Rajendra Singh Pardesi, sir, is though my mentor. He is a host from my side. So we all Amogsians welcome the guest of honor. Madam is senior fetal medicine specialist and consultant in high-risk obstetrics. She has more than 30 years of experience at Lotus Multi-Speciality Hospital. She is the past president of E-Road Obs-Gynae Society and member of ISOG and FOXI. She's faculty in National Fetal Medicine and Obs-Gynae conferences and workshops. We are eager to listen to your precious words, madam. Over to you, Dr. E.S. Usha.
Good evening, everyone. First of all, let me thank Dr. Sneha and Dr. Sambat Madam for this opportunity for being a part of this program. I know this Amogs Emergency Obstetrics Committee is conducting a series of programs involving 3 societies at a time. So this is a nice idea of spreading message across throughout India. So we all know that we are marching towards reducing the maternal mortality. We have already reached some goals, like from near about 400, we have now reached around nearing about 100. So the UN goal is about 70 per lakh in 2030, and I think we will surpass that. That is how we are going. And the meetings like this really help us to spread the knowledge so that everybody is equipped to handle all these emergencies. So we have the current president of Tnfog and the past president of Tnfog tackling 2 important topics. The APH, that is the bleeding is the most common cause of maternal mortality, and that is going to be handled by Dr. Revathi. And peripartum cardiomyopathy is a nightmare. So none of us really actually want to have it. I know Dr. Ramani will give us a clear protocol, and we will see whether doing a routine echo, that what we have started doing, whether it helps in reducing this or at least diagnosing and managing them properly. And I know with the vast experience, Dr. Sneka is going to conduct a panel on labor emergencies. So he's been the chairperson continuously for medical disorders and now in emergency obstetrics. So with her vast experience, we will get clear take-home messages. And we also wish Dr. Sneka, who is that person with her experience and has her contribution to this society, to be elected as the Foxy Vice President for the West. So we are with you, Madam, with our support.
Thank you.
Thank you.
Thank you so much, Madam. I'm very happy to share with you that at present in all the states, AP Telangana, the Gujarat, Northeast, Maharashtra, and all other states, the series of, including Kasuga, the series of these programs of Amogs Emergency Obstetrics Committee are going on, and we have planned 4 to 5 programs for every state. And I'm very happy to share that this is the 13th episode of this program for this series. So thank you so much for all your best wishes, and I'm very happy to be associated with Tnfog. Thank you so much, Madam. Now I introduce and welcome my mentor and advisor, Dr. Rajendra Singh Pardesi, the immediate past president of Amogs. All of you know, sir, so there's no need for introduction. So I straightway hand over the mic to you, sir, for your words of wisdom.
Good afternoon, everybody. Respected chief guest and my mentor, Dr. P.K. Shah, sir. Guest of honor, Dr. E.S. Usha. Amogs President, Dr. Kirtan Kutkoti. Dr. Revathi Janikaraman, Dr. Ramani Devi, Dr. Kalpana Balaburugam. First, I wish to congratulate Dr. Sneha Boyar for organizing this such a nice webinar jointly with TN societies like Madurai, Trichy, Dindigul, Ovijoy societies. And topics are really chosen nice, that APH, peripartum cardiopathy, and emergency, and they will help really in reducing maternal mortality. So Dr. Sneha is doing really excellent job. Our Amogs, we have targeted to reduce maternal mortality in a single digit in these 10 years. Now Amogs means Maharashtra maternal mortality rate is 33 only. It's in the second in India. Now we are targeting single digit, and with the help of and with the efforts of people like Dr. P.K. Shah, Dr. Sneha, and our TN people, and we all, India should achieve it up to 230. With the stalwarts and our legions, you can say legions like Dr. Revathi and Dr. Ramani Devi, I think this will be an academic feast for all of us. I wish every success to Dr. Sneha Boyar for her future endeavor in Foxy, in her future now forthcoming election as Vice President Foxy. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. You all are the witness how we have worked as Best Committee Chairperson and also the Amogs Chairperson for Medical Disorders Committee over the last 2 years now. And this is the third year I'm working for this vice presidential campaign. And not only the virtual programs, but for 3 consecutive years, every weekend I'm traveling to the remotest possible societies of Foxy. I'm enjoying the academics and meeting people. So it's again my humble appeal to support me in my endeavor and vote for me. The elections are from 1st to 10th August 24. So I just see Dr. Parag Biniwale, a dear friend, and who is a national coordinator for Amogs, who have specially joined just to meet all of you and wish us. So I welcome Dr. Parag Biniwale as the national coordinator of Amogs and say a few words.
Thank you, Sneha. Good evening, all the friends from Tamil Nadu. It's indeed a pleasure to be connecting with the Madurai and Trichy Society. I can see Dr. Revati and Dr. Parvatwardhini, and I, very vividly remember the Yuva Foxy conference long ago, which I had attended as a Yuva when I was chairperson of the Young Talent Promotion Committee, and of course, a very dear friend, Dr. Ramani Devi. Sneha, I must appreciate your efforts, and I appeal to each and every one who's attending it. Sneha deserves much better than this, and we look forward we are looking forward to she occupying the very important post of Vice President of Foxy, and I urge all the friends from Tamil Nadu to help her out. I'm sure it's going to be a great learning experience. So thank you, Sneha, and thank you, Tnfog and Amogs for having me here. My best wishes to Dr. Ramani Devi also.
Thank you, sir. Thank you, Parag, for your precious words. And with this, I express my gratitude to all the dignitaries, especially respected Sir Dr. P.K. Shah, sir, Madam Usha Devi, and of course, Dr. Rajendra Singh Pardeshi, sir, and Dr. Parag Biniwale, all the esteemed, panelists, chairpersons, and the president secretaries of Trichy, Madurai, and Dindigul societies, whom I have welcomed already. I'm very happy to have all of you, and thank you so much. Without much ado, I think we should go ahead with the academic session. And for that, I hand over the forum to Dr. Priya Kanappan. Over to you, Dr. Priya.
Thank you, Sneha, madam. Thank you.
Thank you so much.
Can we have the CVs, please, Sahiti? It is such a pleasure to invite Dr. Ramani Devi, madam. Madam is the president Tnfog. She's a national vice president Foxy 2020, managing director of Ramakrishna Medical Center and Janani Fertility Center, patron and president of the Tnfog, executive committee member of Endometriosis Society of India. She's won 10 gold medals in UG and PG, 5 Foxy awards, UNICEF master trainer for violence against women, winner of Dira Award for the violence against women. She's a MS Signature Award for academic excellence and innovation in field work, and Dr. Satyapal Awardee 2022 for Academic Excellence, Asia GCC Award for Academic Excellence 2021, authored more than 30 topics in books and more than 23 scientific papers in her name, a principal investigator in POIS trial published in Lancet, editor of the Endometriosis Update published by the Endometriosis Society, and has citations of almost like 2,536. Excellent, madam. Over to you, madam.
Thank you, Dr. Priya, for your kind introduction. First of all, by the time I share my screen, can you see my screen?
Yes,
Okay. Respected Sir P.K. Shah, Dr. Rajendra Singh Pardeshi, Dr. Usha, Dr. Revati Madam, and dear Dr. Sneka Boyer. Thank you for giving me this opportunity to talk about this peripartum cardiomyopathy, which is a very, very important topic, though rarely spoken about. I feel it is very important. The plan of my talk will be, what is peripartum cardiomyopathy, who gets it, and how to recognize it, and how to manage it. Here, the problem is, it looks like a failure. But why the failure occurs and how, whether it is because of any other reasons apart from cardiomyopathy, and how to recognize and how to manage are certain problems in this particular disease. So peripartum cardiomyopathy happens in 4% of all cardiomyopathies. 1 in 3,000 to 4,000 pregnancies, and invariably it is a dilated cardiomyopathy. See here, there is enlargement of the left ventricle due to dilatation. So according to WHO in 2020, Indian women, they develop peripartum cardiomyopathy at a mean age of 27 years and most commonly during the postpartum period. Hypertensive disorders of pregnancies and anemia were associated with peripartum cardiomyopathy in nearly 50% of the cases. Here, as earlier Dr. Usha has mentioned that, all the previous eminent people who had given the guest talks, everybody is for reducing the maternal mortality worldwide. And here we know that the maternal mortality due to peripartum cardiomyopathy is almost 11.7%, and the fetal mortality is 14.2%. Hence, it should be considered and diagnosis should be made properly and earlier, promptly, and so that we can handle it and reduce our mothers suffering from morbidity and mortality. Mortality figures from multiple small series, they have ranged from 7 to 50%, because no scientific paper has got a large series of peripartum cardiomyopathy because it's quite rare, but it is very important. And half of the death occurring within 3 months of the delivery. The usual causes are heart failure, arrhythmias, and thromboembolism. The maternal mortality rate related to thromboembolic episodes has been reported to be as high as 30%. That means 1/3 of the women died because of thromboembolic episode in peripartum cardiomyopathy. Acutely, maternal hypoxia may lead to fetal distress and fetal demise. How to define peripartum cardiomyopathy? There are certain criteria. Let us see what they are. First thing is development of cardiac failure in the last month of pregnancy or within the first 5 months of delivery. The next point is absence of any identifiable cause for cardiac failure. For example, the patient may be having severe anemia or a rheumatic heart disease or a hypertensive disease. So such causes are not identified. Again, absence of a recognizable heart disease prior to the last month of pregnancy. Then when you do an echocardiography, the left ventricular systolic dysfunction demonstrated by classic echocardiographic criteria, that is the LV ejection fraction is always less than 45%, or reduction in the fractional shortening, that is less than 30%. For a normal cardiac function to occur, there should be good fractional shortening of the muscles of the myocardium so that it can pump the blood against resistance. But that fractional shortening is being reduced to less than 30%. Additionally, the dilatation with left ventricular end systolic dimension is always greater than 2.7 centimeters, which will ultimately lead to dilated cardiomyopathy. So then the next question is, who gets it, or probably what are the risk factors? The risk factors for peripartum cardiomyopathy are, already I have mentioned, hypertensive disorders of pregnancy, be it a gestational hypertension or a preeclampsia, multiple pregnancy, multiparity, and prolonged use of tocolysis like isasuprim in cases of preterm labor where they have used it for beyond a period of 1 month, they are at high risk. And again, smoking. And there are ethnic and socioeconomic factors. Ethnic factor is the African society, the incidence of peripartum cardiomyopathy is very, very high. Again, malnutrition and genetic predisposition, and again, extremes of reproductive age. When a woman delivers at a very young teenage or in the perimenopause, that time the risk is high. To herewith, I would like to share one of my patients who had a peripartum cardiomyopathy. I was so happy telling that she has delivered uneventfully. But on the 7th postoperative day, before getting discharged, she fell down in the washroom and she collapsed. And incidentally, when we went back to the history in detail, her mother also died when she was born, and she was presumingly that she could have also died of peripartum cardiomyopathy. So then comes the other risk factors which were confirmed in certain prospective studies and possible in some of the studies. The confirmed risk factors for PPCM are history of hypertensive disorder, multiple pregnancy, African descent, and maternal cocaine abuse. Then possible risk factors are when a patient is put on oral tocolytic like beta agonist greater than 4 weeks of treatment, multiparasuman, age beyond 30 years, and selenium deficiency. So now to summarize, the proposed pathogenic mechanisms in peripartum cardiomyopathy are, first thing, when a woman is pregnant, first we have to think about the genetic factors, familial aggregation of risk, and race and ethnicity. Then comes the altered physiology, abnormal response to hemodynamic stress of pregnancy, environmental factors like viral myocarditis, bacterial myocarditis, nutrition, and micronutrients. Whenever the patient suffers from viral or bacterial myocarditis prior to pregnancy, she is at a high risk of developing peripartum cardiomyopathy. Then again, post-immune factors, autoimmune phenomena, microchimerism, increased apoptosis, cytokine-driven inflammation, increased adrenergic tone. Then excessive prolactin is found to be one of the important causes, and there is increased production of pre-apoptotic factors and anti-angiogenic mediators. So all this will activation of the cell signaling to regulate myocyte hypertrophy, myocyte survival, apoptosis, angiogenesis, capillary density, and redox, oxiredox potential. So whenever there is a normal signaling, there is a normal pregnancy outcome. But whenever the signal deviates or whenever there is an abnormal signaling, it will lead to PPCM. Then once when the patient has got a peripartum cardiomyopathy, two things can happen for postpartum period, that is beyond 5 months. One thing is it can resolve to normal LV function and size. Or what happens is there may be persistence of LV dysfunction, cardiomyopathy, and again there will be worsening of this LV function in the repeat pregnancy, and ultimately the patient that are proposed by Silva et al. One is in a normal heart, when a patient gets activation of protective cardiac myocyte signaling pathways, it becomes a normal heart. And then pregnancy-associated hypertrophy can happen. And ultimately, when there is abnormal signaling, it will lead to peripartum cardiomyopathy, which can again become normal during the subsequent time, or it can lead to irreversible dysfunction, causing persistent dilated cardiomyopathy. Again, we have discussed what are all the probable causes and the risk factors. Now comes how to recognize it. See, unless we know how to recognize the cardiac failure is probably because of peripartum cardiomyopathy, we cannot manage it properly. The importance of early recognition is there. The delayed diagnosis is often associated with higher rates of illness and death. Physicians should consider peripartum cardiomyopathy in peripartum patients with unexplained symptoms. That is, symptoms of heart failure may be difficult to differentiate from those of late pregnancy. A heightened suspicion can only help. So a patient who is presenting with abnormal symptoms, we have to have a high degree of suspicion when she has associated cardiac failure. So the recognition can be prepartum or intrapartum or postpartum. So usually in the peripartum period, in the postpartum period, only 60% of the patients, they present with peripartum cardiomyopathy, and 30 to 40% it happens in the antenatal period and the intrapartum period. So what are the physical signs mimicking cardiac disease? Because we know that many of the symptoms what we see during the normal pregnancy itself can mimic a cardiac disease. For example, peripheral edema, women tend to hyperventilate, prominent neck veins with a prominent A and B wave, brisk, diffuse, displaced left ventricular impulse because of the enlarged uterus, palpable right ventricular impulse, increased S1 intensity, splitting of S2, and early ejection systolic murmur at the lower left sternal angle or pulmonary area. Then cervical venous hum can happen, and mammary souffle. These are all some of the normal findings which can mimic a cardiac thing. Then in normal pregnancy, what happens is due to the increase of endogenous progesterone, the respiratory tidal volume is increased and the patients have a tendency to hyperventilate. However, the rate of respiration is normal in normal pregnancy. Normal pregnancy is again characterized by the exaggerated X and Y descent of jugular venous waveform, but the jugular venous pressure should be normal. Then cardiac auscultation reveals a systolic ejection fraction at the lower left sternal edge over the pulmonary area, or both in 96% of the women. They can have a soft systolic murmur that is less than 3/6, and this can happen in a normal pregnancy. Then comes the diastolic murmurs. This pulmonic arterial flow murmur tends to become quieter during inspiration. Diastolic murmurs that has been picked up during pregnancy always warrants further evaluation because they are a sign of abnormal cardiac function. Then again, during normal pregnancies, S1 may be exaggerated. There may be a split S2 that will become more prominent due to increased right-sided flow. S3 has been described as a normal finding in pregnancy, and peripheral edema occurs in approximately 1/3 of the healthy gravid women. Then, however, alert has to be made whenever there is sudden changes in the swelling late in pregnancy, which can be abnormal and should be investigated. That is, a patient having a mild peripheral edema, which gets relieved once when the patient lies down, that is more physiological. But whereas when there is a sudden increase in the swelling in the late pregnancy, that is the last 4 weeks of pregnancy, which is not getting subsided with the rest, or when you put in a pressure for 40 seconds, the edema may not get, the fluid may not get displaced. All these things are suggestive of pathological edema. Then, regarding the dyspnea, there are some physiological changes which can happen, or it may be pathological. The physiological dyspnea are, it is maximum around 30 weeks of pregnancy. As I told earlier, the pregnant women, they do hyperventilate, and but the SaO2, the saturation is always greater than 96%. 97%, there is no paroxysmal nocturnal tachycardia or orthopnea. There are no lung signs. There is no gross tachycardia, and significant murmurs, that is S3 murmurs, are absent, and there is only a physiological edema. There is no chest pain or hemoptysis. But whereas pathological dyspnea usually occurs in the last month, respiratory rate is increased, SaO2 may be low, paroxysmal nocturnal dyspnea, and then orthopnea can happen. Then lung signs are present. There is always a gross tachycardia. Significant S3 is present. There is pathological edema. There may be chest pain, and the patient may feel discomfort, and then she can have hemoptysis. So what is orthopnea? The dyspnea that develops in the recumbent position, and it is relieved by sitting up or elevation of the head. Orthopnea can occurs within 1 to 2 minutes after assuming recumbency, and recovery on sitting up is also immediate. So the patient may not be able to lie down, and usually she lies down in a sloping position, that is called orthopnea. Paroxysmal nocturnal dyspnea these are attacks of dyspnea which occurs at night that keeps the patient awake from sleep. It occurs 2 to 5 hours after the onset of sleep, and that takes about 10 to 30 minutes for recovery after assuming the upright position. So this is the difference between the orthopnea and PND. Then edema, how different? It is what I have mentioned earlier. It is always sudden, occurring in the late trimester, significant. It is usually symmetrical and associated with dyspnea, orthopnea, and PND. And if you apply pressure for 5 to 20 seconds, the time taken for the displacement of the interstitial fluid to the neighboring areas. So then again, if the dimple caused by pressure, if it takes more than 40 seconds, it is called a slow edema, which is a sign of cardiac failure. That means it takes, if you give compression, it takes more than 40 seconds for the edema to get relieved. But if it fills within 40 seconds, it's called as fast edema, which is always a sign of hypoalbuminemia. So this is the JVP, which can get elevated during cardiomyopathies. Then pulse and blood pressure, unusual tachycardia, irregular pulse, low pulse volume, and there can be pulses alternate, and systolic BP comes down and the diastolic BP goes up, leading to decrease in the pulse pressure, in contrast to normal pregnancy where the pulse pressure is widened. Edema with high pressure, it happens with gestational hypertension. Edema with low pressure happens in peripartum cardiomyopathy. So on auscultation, you should have a good stethoscope, good quiet atmosphere, listen to the sound, apply the thing between the earpieces. S3 murmurs and lung signs have to be noted. There are certain clues in the last month, unusual symptom on the multigravida, prominent JP, very prominent apex beat, prominent cardiac palpitation, thrills. Can everybody mute yourself? Thrills, rough systolic murmurs, diastolic murmurs, brady, or irregular pulse, abnormal blood pressure, and unusual edema are certain clues to say that the woman suffers from dilated cardiomyopathy. Then intrapartum period. There is a sudden dyspnea with shock. Peripartum cardiomyopathy, here it may present with a sudden dyspnea and shock, and there may be an extensive lung signs, JVP. Pulmonary embolism can happen, and in pulmonary embolism, dyspnea with Rita, kindly mute others. Then pulmonary embolism.
Madam, I'll do it, madam. I'll do it, ma'am.
Okay. Dyspnea with clear lungs, JVP is prominent. So these are the two differences between this cardiomyopathy and peripartum cardiomyopathy and acute pulmonary embolism. And we have to differentiate also from primary pulmonary hypertension, where there are clear lungs and flat JVP. In the postpartum period, like any other patient with heart failure, there will be dyspnea, PND, orthopnea, edema with lung signs. It appears usually within 5 months of delivery. Beyond 5 months of delivery, it's unusual for peripartum cardiomyopathy to occur. And what are the checklists at the last month of the pregnancy? This we have to be very careful because this will help us, give us a clue to identify peripartum cardiomyopathy when a patient comes with the really sick status. For example, when the patient has got unusual dyspnea, orthopnea, palpitations, edema, unexplained cough, and excessive weight gain. So these are some of the features. And again, perform echo if more than 3 factors are present. So I'm happy that Tamil Nadu government has made compulsorily that every antenatal patient should undergo echo. And even in that, it is always safe to have an early first trimester 1 echo to find out which are some of the cardiac lesions which are not compatible with pregnancy. And in the last trimester, because it can pick up peripartum cardiomyopathy, which usually occurs in the last month. So what are the investigations we need to do? One is ECG, 2D echocardiogram or transthoracic echo in needed cases, and then cardiac MRI if we are not able to come with the definite diagnosis. Then X-ray test, laboratory, CBC, renal function test, electrolytes, magnesium, calcium, LFT, troponin, BNP, TSH, and ferritin. If persistent past initial therapy, very rarely the patient may need cardiac catheterization and myocardial biopsy. So this is the ECG pattern where there will be pulsans alternus or there will be tachycardia and so many other things. Then what should you see in echocardiography? There should be chamber enlargement. Valve areas have to be measured because usually because of the chamber dilatation, the valves are also getting larger, and pressure gradients and pulmonary hypertension and ejection fraction. The ejection fraction is usually less than 45%. So this is the normal heart where you can have the systolic contraction is very good, but whereas it is in the peripartum cardiomyopathy where the chamber is dilated and you can have a thrombus in the left ventricle. The factors predicting poor prognosis and persistent LVD. So these are all some of the factors, like whenever left ventricular ejection fraction is less than 27% or left ventricular end diastolic volume is greater than 5.6 centimeters, or whenever there is an intracardiac thrombus, troponin test is positive, then QRS widening greater than 120 milliseconds. These are all the factors which will say that the patient is unlikely to recover from cardiomyopathy. And again, it has to be differentiated from other conditions like severe preeclampsia, amniotic fluid embolism, pulmonary embolism, pneumonia, adult respiratory distress syndrome, and myocardial infarction. And other causes of dilated cardiomyopathy has to be discussed. One is idiopathic or cardiac ischemia, viral myocarditis, PPCM, hemochromatosis, sarcoidosis, post-chemotherapy and radiotherapy. Here, the chances of dilated cardiomyopathy is there. Then comes final part of it is how to manage it. So the general measure is rest, give back rest so that we can avoid orthopnea. The patient should have 8 hours of sleep. Salt and fluid restriction should be there. Anemia should be corrected. Infection should be prevented or managed. Then precipitating cause and identification of proper management should be there. And removal of the offending drugs like tocolysis, it should be done. So now the principles of management of failure are, one is the myocardium is weak. It's a weak heart, which is a failing myocardium. And the preload and the venous return has to be altered. Afterload and the peripheral resistance has to be managed. So now, ultimately, the diuretics and the venodilators are going to help. And vasodilators like hydralazine, AC inhibitors, and ARB should be given. And to improve the performance of the myocardium, we have to put the patient on, digitalize the patient, and inotropic support has to be given. And give rest, and beta blockers should be given, especially metoprolol long-acting, so that it will reduce the tachycardia. So then anticoagulant, is there a role for anticoagulant? If the ejection fraction is less than 30%, or if there is atrial fibrillation, when you see an intracavitary thrombus in the echocardiography, or whenever there is a prior embolic effect or a gross LV dysfunction, dilatation with a poor contractility, then the chances for thrombus formation is quite high. And LMWH before delivery should be given, and warfarin can be given after delivery. Till LV function normalizes, we have to continue. That is at least for a period of 5 to 6 months. Then, is there any role for immunosuppressant agent? Yes, IVIG has shown to improve the ejection fraction in acute dilated cardiomyopathy. And again, a biologically active derivative of prolactin has been found to be a possible mediator for PPCM. Hence, bromocriptine has been used experimentally to treat peripartum cardiomyopathy. Then comes how to manage during intrapartum period. Vaginal delivery is always preferred. To cut short second stage of labor, patient should be put on the left lateral position, oxygen should be given, and all emergency drugs should be kept ready, and IV flucimide should be given for as soon as the baby is delivered, for like any other cardiac patient, and watch closely during the postpartum period. Watch for 72 hours in the postpartum, and IE prophylaxis if there is significant regurgitation. So this regurgitation occurs because of the dilatation of the ring dilatation of the orifices. So now the next one is there may be persistent dysfunction. High risk of relapse with subsequent pregnancies can happen, and 50% show further deterioration with the left LV dysfunction. Increases the morbidity and mortality, and premature delivery and abortion are more common. But there are a group of patients who recover completely. They have a better prognosis in subsequent pregnancies when compared to persistent LV dysfunction. 20% still they can have a relapse. Rate of recovery is higher. Morbidity and mortality is lower, likely to have a normal pregnancy. Careful and close monitoring is recommended. So in the subsequent pregnancy, here recently I had 2 patients with a past history of dilated cardiomyopathy or peripartum cardiomyopathy. See, one patient had reached me at 8 weeks of pregnancy, and the second patient had reached me in between pregnancy when she wants to conceive. So now how we are going to decide whether this patient can continue the pregnancy or whether she is likely to land up with recurrent cardiomyopathy. This is basically, we have to have a basic echocardiography. If the basic echocardiography shows a low normal or a normal LV function, that is, the ejection fraction is beyond 45 to 50%, then probably the patient can be subjected for what is called as dopamine stress test or echo test to assess the contractility reserve and then decide. If by doing a dopamine cardiac echocardiography, if the ejection fraction increases beyond 60%, that means the patient is fit to undergo the subsequent pregnancy, and she is at a lesser risk of developing peripartum cardiomyopathy in the subsequent pregnancy. But if the persistence of LV dysfunction, even after dopamine stress test, or if there is failure of this dysfunction to correct itself, then we can strongly suggest that patient should not go for the subsequent pregnancy. So ultimately, we need a teamwork of cardiologist, obstetrician, and the perinatologist. So to conclude, high index of suspicion in the last trimester should be there. Aware of warning signs, symptoms and signs, and differentiate from the usual symptoms and signs. And there should be a low threshold for doing an echo. So don't fail to do a patient with coming with the abnormal symptoms like dyspnea, orthopnea in the last month, And you should have a low threshold to go for an echocardiogram and an ECG. So that is the ideal way to detect peripartum cardiomyopathy earlier and manage properly, counsel correctly so that we have a good maternal-fetal outcome. Thanks for the opportunity given. Thank you, Dr. Snega. And finally, I request all of you to support me for the ICOG Vice Chair election that is coming up in the 2020. From September 1st to September 10th for ICOG Vice Chair elect for the year 2025. Thank you. Thank you so much.
Thank you, Madam, for such an elaborate presentation, and all the best for your ICOG elections, Madam. We know definitely you're going to win the elections with flying colors. We're all there to support you.
Thank you, Priya. Thank you.
Neha, ma'am, you want to?
I would say it was a very exhaustive and very detailed talk. Excellent deliberation, Madam Ramani Devi. And that is what I had expected from you. So thank you so much, especially for that. Thank you,
Madam. Thank you.
So there are no questions from the chat box. Thank you, Madam. Thank you. So we'll go on to the next session. So the next speaker will be Dr. Revati Janaki Raman, Madam. She's a former director, IOG Chennai. Madam is a vice president of South Zone 2016. She's the president of Tnfog 2023 and the founder secretary, past president of the Madurai OG Society, founder president IMS Madurai chapter, and then president of the MCOT Madurai chapter of Tapisa. She's a recipient of the Foxy Dr. Dusha Community Service Award, recipient of the Lifetime Achiever Award from the IMA Madurai, and she's selected as the master trainer for TP IUCD program. And she's the author of Foxy Focus on amniotic fluid A to Z, contributed chapters in Foxy Focus, and she's been, contributed many chapters for UG and PG books, as well as the Pride of Foxy Award in November 2019 at Mumbai. So thank you, Madam. Thank you. Over to you, Madam.
Can I share?
Yes, ma'am.
Thank you, Priya, for the nice introduction, and thanks to Dr. Sneha for inviting me to be part of this program, and my best wishes to you for a great success in the forthcoming election. APH is an obstetric emergency which occurs in 3 to 5% of all pregnancies. It continues to be one of the most important causes of maternal and fetal morbidity as well as mortality. What we can do to reduce that? Complete assessment and management in a well-equipped hospital with facilities for resuscitation should be undertaken. In case of maternal or fetal compromise, birth should be expedited. The causes of APH can be classified as either placental or extraplacental, of which the placental causes take the big chunk, which is taken up by the placenta previa and abruptio placenta. And the extraplacental causes include cervical polyp, carcinoma cervix, varicose vein, and local trauma. I have seen a case of torrential bleeding presenting as an APH from the vulval vaginal varicose veins. And unexplained takes 25%, excluding the placental or other local lesions. Now let us see one by one. Placenta previa, the incidence is 0.3 of all 3% of all pregnancies. And nowadays we find increasing incidence of placenta previa. The reason is the increasing rate of C-sections. And all the more, when the number of previous C-sections are increased, the more chance of placenta previa to be there. And increasing maternal age at conception and increasing IVF pregnancies are another cause for increasing incidence of placenta previa nowadays. Of course, smoking due to the compensated placental enlargement results in placenta previa. And when there is a previous history of placenta previa, there is an 8 to 12 times higher chance of placenta previa at this time also. Previously, we used to class when we were students and we were teaching our PG students also, we classified it under 4 headings depending upon the distance of the tip of the placenta from the internal os in the lower segment, like type 1, 2, 3, and 4. Recently, multidisciplinary workshop of American Institute of Ultrasound in Medicine recommended the term placenta previa should be used only when the placenta is directly over the internal os. That is placenta previa. Whereas all other things, the term low-lying placenta is used. That is when the placental age is less than 2 centimeters, 20 millimeter, less than 20 millimeter from the internal os, when seen by either TAS or TVS after 16 weeks of gestation. You just name it as low-lying placenta. But there are various risk factors, both maternal and fetal risk factors, which increase the chance of placenta previa. Maternal include uterine scars and pathology. All the more in these cases, the chance of PAS is more. Multiparity, advanced maternal age, placental size, ART pregnancies, and placental pathology like succinate lobe, fenestrated, bipartite, and smoking, as I told you earlier, and previous history of placenta previa, there is chance of recurrence in 4.8% of cases. Fetal, again, multiple gestation, obviously, the larger size of the placenta, and all the more in dichorionic pregnancy, there is a higher risk. And in male, male fetuses, it has been found that there is a larger placenta and also delayed implantation of the male blastocyst so that it gets implanted in the lower segment and there are more chance of a placenta previa. The male starts giving trouble right from utero. A diagnosis is mostly by ultrasound. Ultrasound is a boon to make a diagnosis well in advance, even before the onset of bleeding. And when you do the routine anomaly scan at 18 to 20 weeks, definitely you can make the placenta previa. At that time, the placental cord insertion should also be evaluated, and also evaluation of PAS must be done, more so in case of previous cesarean section or any other risk factors for PAS. And usually the placenta previa remain as asymptomatic one, or it may present as a painless, causeless bleeding, which is likely to stop, but likely to recur again. But remember one thing, when there is no bleeding, even with the onset of labor, when there is a placenta previa, beware, it may be a PAS. Please suspect that. And of course, differential diagnosis between the placenta previa and abruption, all of you know, by means of clinical features, abdominal examination, fetal heart, and ultrasound location of the placenta. Now, this is very, very important. Now, the placenta previa may be diagnosed in the routine scan at 18 to 20 weeks. Just like that, it is the diagnosis is made. I have seen one of my juniors referring the patient from the periphery and threatening the patient that there is an anomaly scan. They have found that it is a low-lying placenta. She has threatened the patient to the great extent that she is going to die because of the placenta previa. Now, you should not go to that extreme extent also, but you should know clearly how to proceed if you make a diagnosis of a low-lying placenta or a placenta previa at the routine anomaly scan. Suppose you find placenta previa or low-lying placenta at 18 to 20 weeks. Next thing is there any risk factor for placenta accreta spectrum? Or is it an anterior placenta with the previous cesarean section? First, look at that. If it is not there, then be happy. Repeat the ultrasound at 32 weeks. And at that time, if you find that the placenta is more than 20 millimeter away from the os, be happy. Give her a routine care. It's good enough. But at that time, if you find that the placenta is still within the 20 millimeter of internal os level, then you see whether it is asymptomatic or symptomatic. She remains asymptomatic. Again, wait till 36 weeks. And suppose if it is still more than 20 millimeter from the os, you can just go for routine care. And otherwise, if it is going to be a low-lying placenta, that is low-lying, but at the same time more than 10 millimeter from the internal from the os, then you can decide whether to go for a vaginal delivery or not. Suppose it is a personal placenta previa, then under steroid cover, you have to take her up for cesarean section at 37 weeks, right? Suppose if you find the risk factors for PAS, if it is there, you should be extra careful. Repeat ultrasound, Doppler, and MRI, confirm the PAS. And there is no PAS, you can go routine for the other side. Suppose if you confirm PAS, then you have to take a different care, which I will tell you in the next few slides. Suppose you find this placenta previa in the third trimester only, when it is diagnosed, depending upon whether it is symptomatic or asymptomatic, you have to consider the management. If she remains asymptomatic even at that time, consider antenatal corticosteroids at 34 weeks and delivery at 36 to 37 weeks. But if she is symptomatic, depends on whether she is stable or not. If she is stable, even if she is symptomatic, maternal and fetal status both are stable, then you can give antenatal corticosteroids if she is less than 32 weeks. And of course, you have to plan for a cesarean delivery at 36 weeks. But if she is symptomatic and unstable, you have to stabilize her maternal hemodynamic status, consider antenatal corticosteroids. Again, you have to go for cesarean delivery only. Now, in asymptomatic patients, when we are waiting, you have to give them proper instructions. She has to avoid intercourse, avoid lifting heavy weight, avoid activity restriction, and she should be made aware of the chances of bleeding spotting, and then she has to report immediately when she has to report us. And also you have to counsel her regarding the labor symptoms as well as any vaginal bleeding. Now, for the candidates, you can just send them as outpatient and treat. Only when they are compliant and they live within a short commute from the hospital and they have 24 hours emergency transportation to hospital. And also you have to verbalize a thorough understanding of the risk associated with the placenta previa. Okay. Now, antenatal corticosteroids, no doubt, you have to give a simple course at 34 to 35 weeks. And if at risk for preterm, you can even give earlier than 34 weeks. Delivery, the time and route of delivery must be decided. The time is around 36 to 37 weeks. And recent systematic review and meta-analysis has shown that placenta to internal loss, if it is between 0 to 10 mm, 43% had vaginal delivery. And if it is more than that, it is 11 to 20 mm, 82% had vaginal delivery. Now, at this juncture, I remember how we taught our students according to the type of the placenta previa. Type 1 and type 2 anterior, we allow them vaginal delivery. Type 2 posterior, type 3 and type 4, we take them up for cesarean section. That's what we were taught. Okay, the type 2 posterior mainly because as and when the head descends, it is likely to compress the placenta and cord and likely to cause fetal distress. That is why it is taken up for cesarean section. And next is symptomatic placenta previa. So far we have seen when they come asymptomatically and we make a diagnosis only by ultrasound. Now, when they come with bleeding, you have to admit immediately, take a comprehensive history, assess the general condition, the vitals, and of course, accurate estimation of the blood loss is very difficult. Still, you can assess the general condition of the patient and the abdominal examination to differentiate abruption and this, as well as you have to evaluate the fetal status. And once stabilized, continue hospitalized bedders and expectantly manage them till 36 weeks, no PV. And of course, the investigations we have to do are CBC, blood group, and RH. And if she is RH negative, you have to give anti-D. There is no need for re-administration if the delivery occurs within 3 weeks. Remember, if there is bleeding with the preterm labor, no tocolytics, obviously. The aim is of expectant management is to prolong pregnancy till the fetus matures. Like if it is a preterm baby and if it is a live fetus, there is no serious malformation, bleeding is not excessive or it stops, and patient is hemodynamically stable, she is not in labor. Only under these conditions, you can give them an expectant management. Of course, you have to give absolute bed rest at least for 48 hours after bleeding stops. And many a times the patients respond to the conservative management, but still remember they are at high risk of recurrent bleed. And when they are under expectant management, can we discharge them back home? It depends upon her condition, number of episodes of bleeding, proximity to the hospital, and compliance. You have to decide according to each patient. Now, when you have to go for an active management of placenta previa? When she goes into labor, when there is evidence of fetal distress, when there's an anomaly, there is no point in continuing, or when there is an IUD, of course, there is no point. And when there is a persistent severe bleeding where the hemodynamic stability cannot be achieved, and where there's significant bleeding after 34 weeks, there is no point. You have to get the baby as well as the mother well. And asymptomatic, when they are on expectant management, they have crossed 37 weeks. Obviously, there is no need to continue. You have to intervene and deliver. And most important thing is the care you have to take on cesarean section for cases of placenta previa. It should be done only by a senior obstetrician and an anesthetist. Blood should be available. An evaluation of PIS is recommended. Choice of anesthesia, of course, regionally is quite safe. Hemostasis of the placental bed is very, very important. Packing, pressure, hemostatic sutures, intrauterine balloon tamponade, all these things can be used to control the bleeding. When there is a focal accreta, you can go for excision. When there's a persistent bleeding, of course, you have to go for the next procedure like a uterine artery embolization or internal iliac artery ligation. As a last resort, you have to go for a hysterectomy. This is for a placenta previa section. Now, PAS, this is a hot topic today as accreta, increta, and percreta, which olden days we call it as a morbidly adherent placenta. This we are used to diagnose only at the time of delivery of the placenta when we find it very difficult to separate it, or when it doesn't separate on its own, or when we try to separate, when it bleeds profusely, we made a diagnosis of PAS. We didn't put this terminology in those days. But the incidence of PAS is 1 in 500 to 700 births, and most significant risk factors are placenta previa and previous cesarean section. This is a point which I want to stress very much because the private practitioners in the periphery or whoever it is, when you take a scan or a previous cesarean section, I first note the site of the placenta, location of the placenta. If it is anterior, find whether it is in the lower segment or not. If it is in the lower segment, please make sure whether there is any PAS, that is placenta accreta syndrome. This you have to evaluate even before the patient goes in for labor or further continues the pregnancy. Okay. Now, increasing parity and maternal age, submucous fibroids, prior uterine surgery, ART pregnancies, prior postpartum endometritis, history of pelvic irradiation, uterine malformations, endometrial defects or ablation, all these things can predispose to PAS. Now, this PAS must be diagnosed antenatally itself. Now that we have got this beautiful ultrasound in our hand, we have to make a diagnosis earlier, even before the patient goes for any problem at all, so that we can manage them beautifully and save their lives. Multiple vascular lacunae within the placenta, loss of normal hypoechoic zone between the placenta and myometrium, decreased myometrial thickness, abnormalities in the uterine serosa bladder interface, extension into the myometrium, serosa or the bladder, all these things point towards the possibility of PAS. Of course, color Doppler helps a lot with the supplementation of MRI. Now, it has been found that there is an associated unexplained elevation of maternal serum alpha fetoprotein also in case of PAS. Now, how are we going to manage PAS once it is diagnosed? Now, it is coming under 4 headings. Number 1 is prenatal care, delivery preparation, delivery per se, postpartum care. Prenatally, what you should do? Counsel them regarding the risk, correct the nutritional anemia, give them antenatal corticosteroids, consider magnesium neuroprotection also. And delivery preparation, multidisciplinary consultation, appropriate IV access, blood products must be made available, DVT prophylaxis, bladder catheter, urethral stents, internal iliac artery, balloons, and just, okay. What happened? Yeah. And delivery proper, either you can go for a cesarean hysterectomy or conservative. And all these things you should plan ahead and then proceed. And postpartum, of course, they will need ICU care. Now, delivery for PAS, the place must be only at level 3 or level 4 hospital. And you should decide delivery before the onset of labor or before any bleeding starts. And time is at 35th week itself. Contingency plan for emergency C-section or hysterectomy, massive blood transfusion, and multidisciplinary management should be in practice. What do you mean by that? A multidisciplinary team? You should have well-experienced interventional radiologists, obstetricians, anesthesiologists, neonatologists, urologists, nursing experts, and blood bank specialties. All this setup must be there to establish the accurate management of PAS and to improve the fetal-maternal outcomes. Intraoperatively, the best approach is cesarean hysterectomy with placenta in situ. And incision in the abdomen is vertical is preferred, and uterine incision should be above the placental edge. Oxytocin is withheld after delivery. No attempt to separate the placenta. Wait for spontaneous separation or decision for expectant or hysterectomy is made at the time. And use of balloon tip intra-arterial catheters in internal iliac artery must be there. And with a continuous improvement of surgical skills level in recent years, many scholars have explored new surgical methods during cesarean section to improve the pregnancy outcomes, like vascular interventional surgery, bilateral uterine artery ligation or embolization, iliac artery balloon embolization, abdominal aortic balloon occlusion, and intrauterine balloon placement. All sorts of things to block so that you can check the bleeding from the PAS. Next, coming to the abruption, all of us know that this is a premature separation of a normally implanted placenta before the delivery of the baby. The incidence is 0.5 to 1%. 30% of the all cases of APH constitutes abruption, and it occurs in 19-25% of women who have had 2 previous pregnancies complicated by abruption. It is initiated by bleeding into the decidua basalis. There is mainly a pathology in the blood vessels there. And in PAH, when there is a sudden fetal demise, think of concealed abruption. You might have seen PAH patients coming with the BP coming down and suddenly FH absent. Now, don't just be happy about the BP. But main thing is that at that time, you have to think of an abruption, make a diagnosis and quickly act. And abruption can either be revealed or concealed. Now, hypertensive disorders of pregnancy is mainly associated with abruption. In preeclampsia 44% and chronic hypertension 1.5%, PROM threefold increase, and smoking increases twofold, cocaine abuse also. When there's a sudden uterine decompression, sudden ARM, especially in twins and all, there's a sudden decompression, there's a likelihood of the placenta to get separated, and multifetal pregnancy, uterine myoma, raised maternal serum alpha fetoprotein, and trauma, direct trauma. Now, this is another point. You have to note where is the location of the abruption. It can be either subchorionic, retroplacental, or preplacental. That you can note in the ultrasound. When it is between the placenta and the membrane, it is subchorionic. Between the placenta and the myometrium, it is retroplacental. And between the placenta and amniotic fluid, it is preplacental. Now, it is found that retroplacental hematomas are associated with worse prognosis for fetus than the subchorionic hematomas. Also the size of the hematoma. The larger the size, the worse is the prognosis for the fetus. And of course, laboratory investigations include hemoglobin, hematocrit, platelet count, grouping and typing, fibrinogen, coagulation studies, metabolic profile, and urine analysis. And how are we going to manage abruption? You have to assess the vital signs. Vaginal bleeding, of course, there is no correlation between the external bleeding and the blood loss, actually, because that may be a concealed collection. And urine output should be maintained. Appropriate IV access with 2 large bore catheters, FFP and blood should be arranged. Early delivery of the fetus is very, very important. With adequate replacement of fluid or blood and careful monitoring, all these things result in good outcome. Now, suppose if she is less than 34 weeks and a small abruption, is there any place of expectant management? But as far as I'm concerned, I don't agree at all. All abruption must be delivered. No need to wait just because it is just 34 weeks or premature, because we do not know how much of bleeding is inside and how much it is going to progress. You cannot predict that. So it is not worth putting the mother for stress. And of course, PPH is the commonest problem both in placenta previa as well as in abruption. You have to take utmost care with AMTSL and preparatory things for correcting the PPH. And prognosis in abruption, the maternal mortality rate is 0.5 to 5%. Complications like hemorrhage, coagulation failure, renal failure, and hemorrhagic shocks are the main cause for maternal death. And they have a 1.8-fold increased risk of CVD mortality in later life. Remember that these abruption patients have got the risk of developing CVD in future 2 times more. And perinatal mortality in these patients is about 4 to 68%. Now, apart from abruption and placenta previa, the other causes of APH are vasa previa, 1 in 2,000 to 3,000 deliveries. It presents as fetal distress, and the diagnosis is by documenting the umbilical vessels over the cervical arch using color Doppler. And of course, when you patient comes with the bleeding, you can confirm that it is a fetal blood by means of identifying the fetal hemoglobin. And vasa previa, as you can see here, the ultrasound picture and the placenta finding. The risk factors are low-lying placenta and succensurate lobe. Possible presenting features of vasa previa include variable fresh vaginal blood loss after rupture of membranes, acute fetal compromise with no maternal shock. Now, this variation, you have to think of vasa previa. And uterus will also be normal. Now, immediate decision is to do a section. Now, in all cases of APH, the maternal and fetal complications are quite high. That is why there is an increased mortality and morbidity. They are likely to go for anemia, fetal hypoxia, small for gestation age patient, and babies, maternal shock, prematurity, both iatrogenic as well as spontaneous, renal tubular necrosis, fetal death, consumptive coagulopathy, postpartum hemorrhage, prolonged hospital stay, psychological sequelae, and complications of blood transfusion. All these problems are there. We have to think of it and manage them adequately. And of course, APH is such a vast subject, each and everything, placenta previa, PAS, abruption, complications of abruption, vasa, everything is there. Each one is a separate topic which needs at least different lectures. But I have tried my level best to compress it in 20 minutes. And thank you very much. And Sneha, my best wishes to you for a great success in the coming election. Also to Dr. Ramni. Thank you very much.
Thank you so much, madam. Yeah, we would first have the comments from the chairpersons, definitely, and then I'll make a comment.
Namal, madam, can you give your opinion, madam?
Madam?
Minamal, madam would talk for opinion, madam.
It's a nice topic, well organized. The recent update also she has shared with us. Thanks to Dr. Revati.
Thank you, Ka.
Madam Parvatavati, madam, you are
Parvata,
muted,
your off, mic on, please.
Yeah, madam, your presentation is very crisp and nice, as
Thank you.
always.
Thank you very much. Thank you. Dilshad, welcome.
Dilshad, ma'am.
Madam, I would choose for his comments.
Dilshad, madam. Madam,
Yes.
can you hear us, madam?
Yeah.
PK Shah, sir. Sir, can you please make few comments on this? Please unmute yourself, sir. Sir, please unmute. Unmute, sir.
As far as Madam Revati's talk is concerned, I think I could not have finished within the time limit that was given to her. That is one thing. But I think she's included almost everything. I thought she won't touch upon PAS when she was talking about placenta previa. But she covered it very well, let me tell you honestly. And Dr. Ramani Devi, I thought I was listening to a cardiologist and not a gynecologist when she talked about cardiomyopathy. It was very good because that is one topic in OBGYN which I am not good at and I don't like to even read. So I think when I listened to Dr. Ramani Devi, I was very, very happy. Let me tell you honestly, she made it very nice and very interesting and very informative. So thanks a lot for having these two great speakers from South, Dr. Revati Janakiram.
Thank you very much, sir.
And
Thank
Dr.
you.
Ramani Devi. Super, absolutely fantastic. Thank you very much, ma'am.
Thank you, sir.
So welcome, Dr. Kalpana, madam. So Kalpana, madam, you want to?
Kalpana is joined?
Yes, ma'am. Yes, sir, she's come.
Yes. Hi, Kalpana. Welcome.
Hello, ma'am.
Hi.
Actually, I've been listening to your words, Pikesha, sir. It is always happy to hear your encouraging words. I was stuck in some other program. Sorry, I came a little late in front of all the giants, and it's a wonderful program organized by Amogs. With their leaders, Dr. Kiran Kurkote sir, Vipin sir, and Rajendra Singh Pardesi sir. I know Sneha ma'am for the past few years, hardworking person, and I've worked with her for years together. And it's pleasure to organize such a wonderful program in Tamil Nadu for her. And we have wonderful leaders, speakers of Tamil Nadu who had shared their knowledge. I've really missed it. And we have experts for the panel discussion who are waiting for their expert comments led by Dr. Sneha. Thank you so much.
Thank you so much, Kalpana, and it's always a pleasure to work you. Just for information of the others, I would just say that right from breast committee, we have been working together, so Dr. Kalpana being the chairperson of the infertility committee of Tnfog and me being the chairperson from breast committee of Foxy. So I don't know how we could manage, organize the programs together. And then of course, with Amogs medical disorders for last 2 years, we have been going all throughout Tamil Nadu. So thank you so much, Kalpana, once again for all the collaboration and all your help. Thank you, dear. Welcome to this program. Over to you, Dr. Priya.
Thank you, ma'am. Thank you. So can we have Kalpana, madam, please? Yes.
No,
so it is my pleasure to invite ma'am.
No, you can go ahead with panel discussion, Dr. Priya. But
yes.
Okay.
Okay, Priya, you can skip my introduction. It has been done already directly. A few points about the panelists, please.
Yes, ma'am. Dr. Dilshad, the former director of ISO KGH, she's a professor HOD of Madurai Medical College, Amog district coordinator, president of Madurai Obstetrics Society, present papers, and she's a consultant in present hospital. Next, please. Dr. Parvatini Vadini Madam, a former professor, Obstetrics, Madurai Medical College. She's a past secretary, Madurai Obstetrics Society 2008 to 10, organizing secretary, Yuva Foxy 2009, executive member, Madurai Society, faculty in national conferences, senior consultant, Akshaya Hospital, Madurai. Next, please. Dr. Selvarani Madam, she's a chief consultant, Obstetrics, fertility and gynecology, former medical superintendent, St. Joseph's Hospital, managing director, Sri Amogam Hospital, and honorary secretary of Dindigal Obstetrics Society. She has done a diploma in diabetology, sonography, laparoscopy, a postdoctoral fellowship in reproductive medicine, and diplomas in reproductive medicine, obstetric gynecology, and cosmetic gynecology, fellowship in ICOG and ICMCH, member of all the societies, and his special interest in infertility and high-risk obstetrics. Next, please. Dr. Meena Ambal Madam, a retired professor and HOD of Obstetrics Department of Madurai Medical College, and she's in government service for 34 years, past president of Madurai Obstetrics Society, Professor Emeritus, Tamil Nadu Medical University, recipient of the Lifetime Achievement Award from the MGR Medical University, first women president of the IMA Madurai branch, chairman Women's Wing of IMA Madurai, and she's conducted many CMEs, workshops, presented paper in ACOG and Manipal, Malaysia, and she's a member of the Indian Menopause Society, Perinatology Society, and received the Dr. Ashirvadam Award for Academic Excellence in 2022 by alumni of Madurai Medical College. Next, please. Dr. Lalita Madam, she's a former professor of Obstetrics Society of Madurai Medical College. She's a senior consultant, Apollo Specialty Hospitals, Madurai, and she's a consultant, Setu Sharada Hospital, Madurai. Dr. Amala Devi Madam, she has served in Tamil Nadu Medical Service since 72 to 2006, founder secretary of the Dindigal Society of Obstetrics, honorary secretary of IMA, and EC member of the Tnfog, EC member of Madurai Menopause Society, at present a senior consultant Obstetrics, Annai Perenbam Hospital, Dindigal, president Dindigal Society, and she's been the zonal chairperson of the Dindigal Lions Club, president of the Dindigal Tamil Sangam, and chairman Women's Doctor Wing of the IMA Dindigal, and she's published books and presented papers and conferences. Next, please. Dr. Tamilchelvi Madam. Madam is the president of the Trichy Obstetrics Society, worked in 12 years in government service, PhD for 4 years, and KFPV Medical College, Trichy. And she has established Arul Hospital, Tiruchirappalli. OG practice serves to be for past 24 years. Field of interest, laparoscopic surgery, vaginal surgery, high-risk obstetrics. Served as a treasurer, secretary, and now vice president, as well as now Madam is the president of the Trichy Society. Continuously involved in all healthcare activities in the villages, colleges, and schools. She served in the IMA Trichy, blessed with family, and passionate for trekking and for Western Ghats. She's gone many times, as well as she's involved in the Himalayan trekking 4 times. Excellent, Madam. That is, like one of the things which we don't see in anybody's CV. So congratulations on that. Dr. Uma Velmurugan Madam. Madam is the secretary of the Trichy Obstetrics Society. She's a managing director and the chief consultant. And she's a consultant of Obstetrics Society of Obstetrics Gynecology Department of Apollo Specialty Hospital. She has been the organizing chairperson of the Rockford Annual Fertility CME and conducted the RCOG Advanced Training Modules. And she has been part of many reproductive medicine and advanced labor workshops. So welcome to Dr. Uma Velmurugan Madam and Professor Dr. Mahalakshmi Madam. She's been the president of the Madurai Obstetrics Society, professor of Obstetrics at Madurai Medical College, passed out, she's been the secretary of Madurai Society in 2017 and 18, completed 27 years in government service, worked as a professor in Tirunelveli and Theni Medical Colleges. She has been the district emergency obstetric care trainer, and she's assisting a lot of organizing programs in various conferences. So, and Dr. Padma Madam. Madam is a senior consultant, head of the Obstetrics and Gynecology Department of Meenakshi Mission Hospital and Research Center. She has been a very well known laparoscopic, hysteroscopy, and robotic surgeon, a special interest in gynecologist, awarded the Certificate of Excellence in 2023 by the European Society of Gynae Oncology. She is the present secretary of Madurai Obstetrics Society. She has been the treasurer in 2019 to 21, past president of the IMA Madurai Meenakshi branch, and been the past joint secretary of the Association of Gynae Oncologists of India, past secretary of Vijayawada Obstetrics Society, past secretary of the AGON Con 2007, organizing many conferences, and she's presented many papers and posters in international conferences as well. Welcome to you, madam. So, Over to the moderator and the panelists.
Yes, thank you so much, Dr. Priya. In fact, wonderful job for coordinating with everybody, and of course, the flawless conduction you have been doing.
Thank you, madam. The credit goes to Kalpana, madam.
Yes.
So she did the major
Yes.
job there.
So thank you so much, dear Kalpana, as well. And without much ado, I would just straightway go to the panel discussion. I hope my screen is visible, and I will just try to make it full screen. So all the president secretaries of Madurai, Dindigul and Trichy, I have welcomed initially itself. Once again, I welcome all of you and I welcome all the panelists here. So friends, childbirth is a sentinel event in the life of a woman, not only the woman, but her family. And birth is intensely emotional as well as physical. I think, Saiti, if you can mute rest everybody apart from the panelists, that will be great. So,
Okay, ma'am.
birth is intensely emotional as well as intensely physical, and it is not that easy. 1, 2, 3, and 3 pushes, and the baby is delivered like it is shown in most of the movies. But it is a very, very difficult procedure, I would say. And what the textbook says that normal labor or normal delivery is a retrospective diagnosis. I'm sure. No, I mean, you always feel that, your patient is just about to deliver. Everybody is waiting for that moment so that you can relax. And in no matter of time, you find that your patient is in ICU. So that difficult it is. The aim of the delivery is, of course, the healthy baby from a healthy mother who should have an emotionally fulfilling experience. And of course, even today, the dilemmas, especially regarding the second stage of labor, remains for not only the obstetricians who are learning it as a new trainee, but also those who have been practicing over so many decades, including me. So definitely, we have certain cases which I would like to discuss with you. So we start with this first case. You have this 35-year-old grand multipara. She's delivered by a dai at home. The placenta is also removed, but she's brought to the labor ward with profuse bleeding. Her vitals, pulse rate is 120 BPs, 90 by 50 millimeter of mercury. So what is your provisional diagnosis from these findings? From these findings only. Who is going to take up this case? Anybody can volunteer. Yes. We can go ahead serially, I think. I think Professor Dilsha.
Placenta removed.
Yes.
Patient is brought to that multipara with
multipara who is delivered at home by dai.
Whether the uterus is palpable, madam, per abdomen.
Yes, that is why I'm asking you, what is your diagnosis at this point of time? I'm going to give you the findings. So,
postpartum hemorrhage.
Very good. Very good. So, Madam Minambal has already said that it is just postpartum hemorrhage. But then definitely when we give you the findings that per abdominally the uterus fundus is not felt, locally you have lots of bleeding, and when you try and do the per speculum examination, large fleshy mass is seen. And of course, even per vaginally, you feel the large fleshy mass. You can't feel the cervical ring. Now, what is the diagnosis?
Madam, this is acute inversion of the uterus.
Yes. So how will you
being a multipara?
How do you manage rather?
Madam, once we diagnose, the patient is in a state of shock. So this shock is not only hemorrhagic and also neurogenic.
Yes.
So we have to concentrate on that also. Immediately we have to simultaneous resuscitation and repositioning of the uterus. Whatever be the that should be taken immediately. So simultaneous resuscitation, you have to follow ABC and prompt recognition. So of course, we have recognized that it is a
Yes, madam, I would just like to interrupt you here, Dr. Dilsha. See,
yes.
The uterine, you're very correct that you have to do everything simultaneously, manage aggressively the shock, but you have to repose this also. But if you can see for this case, she has delivered at home and brought to you, after some, so at least a few hours have been, already lapsed. So is it possible to repose this immediately?
Yes, madam. Yes, madam.
Yes.
The manual reposition should be done immediately under anesthesia.
Under anesthesia. If it happens, if you are delivering the patient and you are removing the placenta, then it happens, you can, repose without anesthesia, correct? But then
Yes,
if
madam.
it is the time
Immediately.
that-
Right in our face if it happens before that constriction ring has not yet formed.
Yes,
That's,
perfect. That
we
is.
have to replace it immediately. Whatever be the portion which has come last, it should be replaced immediately, where you have to keep the fleshy portion over your palm and placing your fingers over the posterior fornix and gently give an upward pressure. At the same time, we have to guide one hand, keep it in abdomen so that you receive whatever be the portion it comes. And once it comes, you have to give uterotonics.
Yeah. So yes, anybody wants to add anything here? When you repose the placenta, see you are doing it, squeezing it, the cervical. The part which comes last will go in first, and then gradually you will push in the fundus, right? So whether
Yes,
you
madam.
keep your hand inside the uterus. Or
Yes,
you
madam. Yeah. Yeah, it should be kept and slowly you have to give upward pressure in touch with that. Once the part which has come last, it has gone in, and if half of the part has gone, the uterus naturally flaps inside the abdomen.
Yes.
That one hand to be kept over the abdomen to receive that part.
Yes, the left hand should be on the abdomen. That is what. So two things, you keep your fist or the right hand inside the uterine cavity for some time, and you support it with the opposite hand, the left hand, right?
Yes, madam.
Okay. And of course, you have to continue giving the uterotonics simultaneously.
Yes,
okay.
madam.
How long do you want to give the uterotonics? How long do you want to continue this?
It should be continued at least for 6 to 8 hours. And because it should not recur, madam.
Yes.
So we have to keep the uterus in a contracted
That's
state.
the message we want to give. Suppose
And the patient must be monitored.
Yes, yes. So suppose your manual correction is not, it doesn't help. Then what are the other measures you can take?
Yeah, where you can go with O'Sullivan's hydrostatic replacement, madam. So this happened once the constriction ring has formed, where it is not possible for us to have a pressure and keep it up, manual replacement, where we have to go with this hydrostatic replacement, where we are going to prepare a warm saline and just placing an intravenous catheter into the posterior fornix. At the same time, you have to close the labia. If you give that patient, before that, the patient must be kept in a tender number position, and the water level should be 2 meters away, above the patient's level. And when you rush the fluid, what happens? It will distend the posterior fornix. So the vagina is distended and it is stretched. When it is stretched, the cervical orifice also becoming little increased. Once it gets increased, we have a place to replace it.
Correct. So suppose even this measure fails, then Madam Parvada, can we have further discussion from your side?
Yes, madam. When this manual reduction and hydrostatic approach fails, we have to take the patient for surgery. We ship the patient to the OT with all facilities for blood transfusion and blood products available. We have to make it sure. We call the anesthetist. And we, in the pupil inversion, we go by abdominal approach. We open the abdomen and we see the inverted uterus as a cup with the round ligament, infundibulopelvic ligament, and uterus drawn inside.
Yes.
We can take this Babcock's forceps and we can gently pull the round ligament, and gradually we'll be pulling by keeping the Babcock's alternatively on the median side, so that we will be able to get the uterus out. Sometimes we may require another help from vaginal side. So this can be a bimanual procedure, one from above and one from below. Suppose if the constriction ring is already formed and the patient came a little bit late, we have to go in for surgical approach where we cut the posterior surface of the uterus, open the pouch of Douglas. Then we'll be able to deliver the uterus and we'll suture the wound per abdomen itself. Then after repositioning of the uterus, we have to see for the bleeding and we have to continue the uterotonics as already said. And the uterotonic should be continued for another 6 to 8 hours. And we have to monitor the patient for all the vitals to be stable.
Yeah. And of course, the antibiotics you have to give, right? So, Madam Parvata, you have discussed it very nicely. Only one initial point. You may have, when you just see this kind of dimple in the uterine fundus here, when you open the abdomen, you can pack the bowel and you can just, use your 2 hands without using the instruments. You can put one anteriorly and one posteriorly, and with the help of your fingers, you can just flip it upward so that, the dimple portion of the fundus can rise up. So, of course, other measures you have discussed it very nicely, that gradually you go step by step ahead. You, with the help of gap cuffs or at least forceps, you can, pull it gently, the round ligaments, and you can bring the uterine fundus into position. Of course, when you have this cervical constriction, to increase the size, either you can stretch manually and then you can try and repose the uterus in its normal position. And of course, if it is still not possible, you may just incise the cervical ring either anteriorly or posteriorly, what is labeled as Halton's procedure. And then of course, you can repose the fundus, so you can pull up the fundus here. Similarly, you have this balloon, pressure, or even with the help of the venous cup, you can try pulling this fundus upside. So that is how these are the procedures, though this is quite a rare or uncommon procedure.
These things are for something like chronic inversion. We don't go in for the vaginal approach for acute.
So that is why we don't encounter these patients or these situations nowadays very commonly. As you have rightly said, that chronic inversion of the uterus, I think these are the methods which you have, this Spinelli's and Kushner's method also. So of course, failure of everything, if at all the uterus becomes gangrenous, then you may have to go for, hysterectomy. All of you know this. Whatever management, post-operative management, you have discussed it well, that the oxytocin have to be continued for at least 8 to 12 hours, and you have to start with the antibiotics, broad spectrum antibiotics. What oxytocin you prefer for these patients?
20 units of oxytocin, 500 ml of saline initially, followed by IM 10 units of oxytocin, and we have got the variable of oxytocin, carbitocin nowadays, which is long acting, which doesn't require repetition of doses. And we have to wait. If the patient doesn't bleed, it's better. Otherwise, we go in for this carboprost injection or misoprostol tablet, 600 to 1000 milligrams per vaginal or per rectal we can give.
Correct. So you have discussed the case very thoroughly, madam. So
one more thing, madam.
Yes,
suppose we have seen acute inversion of the uterus with the placenta in situ. Placenta not yet removed due to mismanagement of the third stage. What we are going to do? It is very difficult to reposition the uterus with placenta in situ, but we have to try that under anesthesia. And after repositioning of the uterus, we have to remove the placenta. If you start removing the placenta prior to repositioning, there will be torrential bleeding and the patient is likely to go in for hemorrhagic shock.
Correct. So our patient already had the placenta removed. That is why we have discussed this. But a very valid point you have to brought out, that you have to, remove the placenta manually after correction of the inversion of uterus. So thank you so much, madam. And now we go ahead with the second case, Dr. Selvarani. This is a case for you.
Yes, ma'am.
Dr. Selvarani. Yes.
Good evening, ma'am.
Yeah, good evening, good evening. Nice to see you. So we have this primary gravida, 37 weeks. She comes to you in early labor. Her vitals are, normal. She's stable. She's got only mild contractions, 25 seconds, 4 to 5 minutes. Head is floating and the fetal heart is good, 140 per minute. Suddenly you find there is a drop in fetal heart rate, significant drop in fetal heart rate. What is your diagnosis at this point of time, and how do you confirm the diagnosis and manage this patient?
Ma'am, she's a 37 week, she's a late preterm, ma'am, and she's having a mild contraction, sudden drop in fetal heart rate. There may be predisposing factors like she may got polyhydramnios or any malpresentations.
Head is floating.
What is
yes,
yeah. Yes,
maybe
the hint is given in the history and examination. The head is floating and there's sudden drop in fetal heart.
fetal
prolapse.
Yes, you say it.
Any placental cause could be cord compression, placental causes could be there, placental abruption may be there.
See, you can see the contractions are 25 seconds every 4
mild
So how will you confirm? That is what I'm saying. What is the diagnosis? What is your differential diagnosis? Sudden drop in fetal heart rate like this.
Cord compression.
Could be the cord prolapse, ma'am.
Yes, it is. But then that is what I'm asking. Cord prolapse can be your differential diagnosis, one of the differential diagnoses.
Yes.
How would you confirm? How do you confirm cord prolapse?
By pelvic examination.
The clinical examination.
How do you go ahead? What all findings you can have here?
By clinical examination, we can assess her
vaginal examination.
Clinical pervaginal examination.
Okay. Anybody else want to take up this case? Doctor?
It is not fitting in properly. So when the head is not in the lower segment,
yes,
cord may be, when it must have ruptured the membrane or it may washed out.
Yes.
There may be a cord prolapse. And because it's a preterm baby, if there is other abnormality like malpresentation,
no. It is head floating. There is no other malpresentation. It is floating head. That's all, madam. Near term, 37 days.
Or maybe a long cord.
So your diagnosis is, I accept your diagnosis as cord prolapse. How would you confirm? That is what my question is.
The pelvic examination, you have to feel the cord, but you should not meddle with the cord. Pulsation, you have to feel. And you have to replace it inside the
first and foremost examination, you have to see whether the patient has ruptured her membranes. Just, you expose her, do her perspiculum examination. Maybe just ask her to cough, see that whether she's got leaking at this stage. Okay. Once you confirm that, yes, she's got rupture of membranes, then you will do a gentle speculum examination to see whether the cord is just lying there. And then you decide whether you should touch the cord or no. Correct? Then, of course, how would you manage this? Because here, see, abruptio, does it fit it here? The patient doesn't have tense, tender, woody hard uterus. Okay.
Immediate delivery.
Yeah. So
the decision depends on the dilatation and the cord, whether it is pulsating or not.
Early
if
labor.
it is early labor,
yes,
with the cord prolapse, you have to decide for abdominal delivery. If it is fully dilated cord, you have to push it above and you can offer a vaginal delivery in such patients. You should be very careful. Even if we decide for cesarean section, before taking, we immediately transfer to theatre.
Perfect.
Before taking for section, again feel the cord pulsation. If it is pulsating, then we can proceed with the cesarean section. Otherwise, if the pulsation has stopped, we have to leave it. for vaginal.
You are very, very right, madam, that because if in a case of, cord prolapse, you don't have to wait for anything. You have to see whether the baby is alive, see for the cord pulsation, and you have to arrange for the operative delivery, whatever. You have to see to it that the baby is delivered at the earliest by whatever modality possible. Okay, if the baby is, she's getting delivered at the earliest vaginally, maybe you apply some instrumentation, forceps, or even ventouse. But if it is not so, then you have to, arrange for the operative delivery, that is cesarean section. Meanwhile, what conservative, what supportive measures you can take? What position? Yes.
We have to avoid the compression on the cord. By properly positioning the patient, keep the cord inside the vagina, because the warmth will be saving. If it is exposed outside, the exposed outside temperature may cause a spasm of the umbilical cord vessels. Keep it inside. Shift her to the theatre with the position, niches position cannot be possible for these women. You have to keep the buttocks a little bit above, and you have to shift her, take her for section immediately.
Yes. So either a left lateral, very deep Trendelenburg position, or a knee chest position, 4 limbs she has to come on, and of course the oxygenation. Madam Amala Devi, I would ask you at this point of time, should we give her any tocolytics? Should we infuse, do the amnio infusion to avoid the cord compression?
No.
Amala Devi, madam, do we have Dr. Amala Devi? No, I don't see her. Dr. Priya, do we have Dr. Amala Devi? No. So you can continue, madam. Should we give her tocolytics? Yeah.
There is no use of giving tocolytics. If there is a violent contraction, we can take care immediately. But it's a mild contraction. In this patient, it's a mild contraction. So no place for tocolytic.
Yes, definitely.
And
a very strong contractions, then only there is a role. If at all, that too, only till you arrange, for the cesarean section, only in between when you are trying to, shift the patient or maybe you're trying to make the arrangement for cesarean section, and that is taking time. Otherwise, it has to be a rush cesarean section. That is what the message we want to deliver here. So can we avoid this situation? Can we avoid this situation? You know the history and the clinical findings for this patient. So can we avoid this situation? I would ask the other panelists, Madam Lalita, I can see.
We have to anticipate the problem like card presentation or card prolapse when there is a ill-fitting presenting part.
Yes.
Footling presentation, transverse lie, or when we do a surgical rupture of amniotomy. When we do amniotomy, we should be very careful to look for umbilical presentation.
Yes.
And also in a multiple pregnancy.
For this patient, madam, I would like to interrupt you. For this patient, I'm asking you, could it have been prevented? You have the patient of, floating head, early labor. So could this have been prevented?
By scan, we must assess the card presentation.
What is the role of admission, like how you have the ultrasound on a labor room admission, or maybe you must be having the admission test as NST. So is there any role of such test or admission sonography to the labor room? And then whether you can predict that, yes, there is a possibility of cord prolapse or maybe the cord presentation?
Cord presentation or long cord or a low-lying placenta, the cord may be in the lower segment. So we have to anticipate this problem in such a type of patient. We should be very careful.
Yes. So the message here is, first and foremost, whenever you have the malpresentations or, transverse or oblique lie or either, very floating head at or near term, the best way is to do the ultrasound and rule out the cord presentation first and foremost. If at all you find that the cord is presenting, that means it is lying in between the presenting part and the amniotic membranes, then of course you have to see to it that this patient doesn't go into spontaneous labor. This patient doesn't go into spontaneous rupture of membranes, or you yourself don't do the amniotomy. And of course, this is a patient who is straightway for cesarean section. That is the only way you can avoid this catastrophe and prevent this perinatal morbidity or mortality. If at all you have such kinds of, now for this case, because it was a floating head, you are not supposed to do this artificial rupture of membrane. This is one. But whenever the patient goes into spontaneous rupture of membranes, you have to make sure that you do her internal examination and keep a watch on fetal heart rate, so that you don't miss on the fetal distress here. So that is all about this case. I think the message we have given. Of course, this is a theoretical aspect, that what are the predisposing factor and what are the aggravating factor. How can you prevent? So I think Madam Meenambal, you can talk about this. Though
Already, these are all the causes for cord presentation and the cord prolapse.
Yes.
Prematurity, polyhydramnios, when the membrane rupture, it will wash out the cord.
Right.
And also in a ill-fitting lower segment, preterm baby, abnormal presentation, twin pregnancy, all are prone for cord presentation, cord prolapse.
Yes. So there should be absolutely no attempt for artificial rupture of membranes, and try to see to it that, whenever she ruptures her membrane spontaneously, you do examine and confirm that there is no fetal distress or cord prolapse. And of course, you don't try and, go for manual rotation of the fetal head, especially when the head presenting part is quite high. So these are the RCOG grain top guidelines, that even if this is a quite uncommon situation, these are the majority of these cases, they come into for case discussions, as far as the litigations are concerned, and routine ultrasound on labor room admission, elective admission for transverse lie breech presentation at 37 weeks. And as we said, that avoid artificial rupture of membranes, and of course, keep a watch on the spontaneous rupture of membranes. And of course, you see to it that the patient doesn't have cord prolapse. Before that, you have to go for cesarean section. So these are the precautions which we have already discussed. Early identification of the patient at risk, and early detection of the cord presentation or prolapse, and prompt management. That is what is the message here. So this is a case for Dr. Lalita now. Hello. Madam Lalita, this is a case for
Dr.
you.
Lalita madam and Dr. Amla Devi madam could not join, ma'am.
Okay, so
Dr. Selvarani madam is there.
Yeah, Dr.
Parvatavati madam is there, madam.
Parvata, Madam Parvata, I think you can take up this case, or Dr. Selvarani, are you here?
It's
Selva.
Yes, ma'am.
Yes. So this is a case for 28-year-old, fourth gravida, 3 spontaneous labor abortions. Now
Yes,
39 weeks in labor. She delivers a full-term baby girl. Placenta is not expelled even after 45 minutes. And what is your diagnosis, and how will you tackle this case?
She's a higher order of birth, because abortion 3. We are not known this abortion 3 was complete abortion, or she is underwent of MTPs, that was a curatages or not. So now placenta is not.
First we discuss or come to the diagnosis. What is the diagnosis? Then we discuss how to
retained placenta.
Retained placenta. Placenta is adhered. So we have
How do we know? How can we say that the placenta is adherent? Clinically, we just come to the conclusion that it is a case of retained placenta.
Retained placenta.
Okay. Now you tell me, how do you confirm that it is whether it is a morbidly adherent placenta or PAS, or it is
So if we have to ask for any ultrasound details, ma'am, with her.
So previous ultrasound done, they are showing normal. What do you do now?
So we have to, if the placenta is not delivered, we have to try for the control cord traction. We have to.
Do you want to rule out placenta, adherent placenta at this point of time also? The previous ultrasound can be wrong also. They haven't
I'll do the immediate labor room ultrasound by myself, ma'am, to rule out the placental invasion.
Yes, that is
At the
what we want to say. That is what we want to say, that you have to do, even if the previous ultrasound says that it is not, I mean, they have not made any
where the
comment.
placenta is, ma'am, where the placenta is located.
Okay, now you tell me, how will you manage this case?
If the placental is situated in such a way, definitely I'll put the Foley's bladder to be drained. So I'll put the CBD.
Okay, go ahead.
Removal of the placenta.
I'll start oxytocin, whether the uterus is contracted or not.
Okay, so have you ruled out that it is not placenta accreta or adherent placenta?
If the placenta is not accreta,
then only you will start.
I'll try to.
Okay, we can
we have to
continue
take
the discussion. Dr. Meenambal, madam, you can take ahead. Yes.
We have to take her to the theater. We have to already she has put in a catheter, so bladder descended won't be there. So, and in the theater, under anesthesia, we have to follow the cord, go to the edge of the placenta, try to remove it manually. If it is very adherent, we have to be very careful. That even if we leave behind few bits, there is no problem. And we have to follow her with the postnatal antibiotic and put in a.
Yes, you will go ahead with the manual removal of placenta only when it is not adherent. Okay, only when it is not morbidly adherent. For a morbidly adherent placenta, we will not take her for MRP.
If it's morbidly adherent, you can leave and you can follow her with the methotrexate other drugs later.
Okay, so how do you do the MRP?
We have to under GA, we have to follow the card, go to the attachment of the card, then follow that to the edge of the placenta. Then from corner, we have to remove the placenta. We have to remove it out. If it is retained placenta, morbidly adherent, we have to leave behind and we have to give drugs.
If it is a morbidly adherent placenta, the management is totally different. We have to rule out that it is, not or morbidly adherent. Then only we can go ahead with MRP, manual removal of placenta. And as you rightly said, you catheterize the bladder, you give oxytocin, you take her up for, MRP and anesthesia. The way you have discussed that you have to, go to the edge of the placenta and gently separate the edge of the placenta, then separate the whole of the placenta, and with the same hand you come out as if you are turning. Once you separate, you turn the placenta as if you are turning the pages of the book. That is how it is described. And then you take out those placenta, and then what do? Then you examine the placenta.
Well, after delivery, we have to examine the placenta, whether we have left behind any cartilage inside, anything, whether it is entire. Or maybe a success rate will be there. So we have to look for the examination of the placenta after delivery.
Yes, both the aspects, the fetal and the maternal aspect, to see whether any lobes of placenta, even the substantiate lobe or the cotyledon as written inside, that you have to rule out. Then you, of course, give oxytocin, continue oxytocin and the antibiotics as well. Okay, so that is about the, the MRP. If at all it is adherent placenta, you have heard the talk, how Madam Ramani Devi has discussed that, the management is definitely, it is not Ramani Devi, Revati Madam has discussed about it. And of course, you have to manage it surgically. Of course, the modalities are different, whether you have to go for the planned obstetric hysterectomy or whether you have a choice of, going for uterine conservative surgery, because nowadays the concepts are changing. Maybe around 3 years back, whenever I used to, deliver a talk or moderate a panel on PAS, I used to always say that, or maybe the consensus was that it should be a elective obstetric hysterectomy, but nowadays with so many advances in the management and so many successful surgical managements also, we have come to the conclusion that even the uterine conservative surgery, first and foremost with the triple P procedure, is possible, and of course the uterine conservative surgery with the Comog MG stitch, that is also possible. Somebody talked about methotrexate. So what is your opinion about using methotrexate, madam? For the retained placenta, what is your opinion about using the methotrexate? Does the evidence support to use methotrexate and leave the placenta inside, or how?
Madam, methotrexate has very strong side effects on the mother. So nowadays we don't advise misoprostol when you go for conservative management.
So basically, even we have done this kind of management when, long back, maybe 3 decades before, but the evidence doesn't support the use of, methotrexate nowadays, or leaving the placenta inside, because all of you know that if it, gets separated, sometimes the patient goes into septicemia, maybe she goes into torrential bleeding, secondary PPH, and then that condition, it becomes very difficult for, the patient becomes moribund. That condition, going for hysterectomy, becomes all the more difficult and risky for the patient as well. So if at all, you have to manage it then and there only. That is what the dictum is. So nowadays there is no role for conservative management, leaving the placenta behind. Yes. So that is what the evidence say. So now we come to the 4th case now, Dr. Dilshad. This is a case for you. Yes, this is a case for you. You have this second gravida para 1, now 36 weeks pregnancy, and she comes to you with previous normal delivery. Okay. Second gravida, previous one normal delivery. Now she's 36 weeks pregnant. She comes to you with strong labor pains. So vitals are good. When you examine that, the uterus size is good. It is breech presentation. Fetal heart is 140. But when you do internal examination, before you do internal examination, you can see the breech. The cervix is fully dilated, fully effaced, and you can find breech at station 1. How do you manage this case?
Madam, this is a case where it is a frank breech.
Yeah.
The patient is having full cervical
How do
dilatation
you know it is a frank
and
breech?
good contraction.
Dr. Dilshad, I would.
Yes, madam.
How do you know that this is a case of frank breech, or complete breech, or incomplete breech, or foot link?
No, we feel only this buttock region, madam. We cannot feel the other part. That is either that knee or the toes. All these things are being, foot is not being felt.
Yes, I have
only
said
that
it's a
portion.
brief presentation, so I have not given you the details whether only the buttocks or the both the feet are felt. So it is only breech presentation. Okay.
Yes.
So how do you manage this case?
Madam, this is a case where the impaction of the breech, that it is +1 station, so it has crossed the cavity.
Presentation. We have not said it is impacted. At no point of time. It is in fact coming very fast down. It is station +1.
Yes, madam.
Okay, so how do you manage this case? Whether you deliver her vaginally or you did?
Yes, madam. It is +1 station, and of course, pelvis is adequate, you told. So when the pelvis is adequate, the breech is +1 station, having good contraction, cervix is dilated, we can still wait and it will descend down, then we will conduct delivery. And if at all, if it is +1, where it is not being descending, we can give steady finger traction over the groin, madam.
Any
so that we can pull it down to the contractus level.
Yes, Dr. Dilshad, I got your point. Any difference of opinion here, Madam Parvatha, Madam Minambal, whether you have differences of opinion here?
Breach, the position.
Breach at the level of +1 station.
We know manipulation.
If it is extended breech, it is very difficult to bring down the feet, madam. Only if it is flexed, we are able to palpate the foot or foot link, then only we can pull the baby down.
Yes. Okay. But then suppose you give me your, suppose this is your patient, madam, how do you manage? To your surprise, she comes in fully dilated, comes as fully dilated, fully effaced with breech presentation. Whether you decide to take her up for cesarean section at this point also, or you go for vaginal delivery?
I go for vaginal delivery.
Vaginal delivery, madam.
That is
Plus one
supposed to-
station.
Yes. Okay. Okay. Suppose the bridge gets stuck, then?
Yeah, in the case, madam, we can go with the compression, decompression.
No. You wait for the bridge to climb up the perineum, then only we can do any assistance.
In this era of CPA, do you really
Yes.
want to deliver the patients with breech?
And the size of the baby, madam.
Decidedly, when the baby, you are talking about the breech getting stuck and the rest of the baby getting stuck. So what else you want to suggest? Madam Minambal, any difference of
Madam, size of the baby, madam. Size of the baby.
the patient?
It is
Size
still,
of the baby, madam.
it is sky only. You have to come up to the outlet. Then only we can do any manipulation.
That is what I'm saying. It is only +1.
You have to come to
Wait for some time, madam, for the contraction to come. Even if it is in +1, madam.
Meanwhile,
you
do
can
you
go-
want to do something? Suppose you are
Yes,
waiting.
madam.
Suppose she doesn't deliver. You are just waiting. So if the baby gets stuck, then what will you do?
Breech disc.
Or
can go-
meanwhile, I would suggest that, yes, she has had one vaginal delivery. That is a plus point you are taking. You are also right, because that is what we consider in the Chatterjee Andrews score, right? But
Madam,
then you feel that, she may deliver, but in spite of everything, you keep all the arrangements for operative delivery, cesarean section ready. Okay, at any point of time, this baby can, get stuck up, and then you're not left with anything. So that there you call the anesthetist, keep everything ready for even if it is at +1, so what? It's not going to, if she delivers spontaneously, very well, very good, right? But if she doesn't deliver spontaneously, then what will you do?
Can we go with this Spinard's breech decomposition? Can we have any manipulation?
Yes.
And
Tell me. Suppose, how do you
Yeah.
deliver? See what
Except that in Spinard decomposition, breech, where you have to insert 2 fingers, madam, and follow the thigh and feel the knee. And once you keep it little away from the midline, the knee may drop down. In the case when you bring it to the into the vagina, then you can have little traction, because there is no CPD, average baby, full cervical dilatation. So this will deliver the baby.
Yes, but breech is notorious, Dr. Nilshat. Any point of time it can get stuck. Okay. Suppose you deliver everything and the after coming head only gets stuck.
Madam, we have to bring it up. We do all these things. It has to come up to the level of the introitus.
Okay. Now you now
we are in the theater with the anesthetist.
Yeah, let me
everything
tell
is
you.
ready.
When
the breech is not progressing, we have to decide for section only. If there is no progress after that, +2, 1, it's not coming down.
Madam, in this patient, whenever there is a impaction, if it is at the brim or at the level of the cavity, we go with section, madam. But here is the patient, the breech has crossed beyond the cavity, beyond the spine, that is in +1 station. We want the breech to come up to +2, that is to the introitus level.
Yes. You
So
are
can we
right,
give some time for good contraction?
But see, breech is very notorious. Anytime it gets stuck, you have so many things, extended legs, you're doing Peanuts maneuver. Okay, I'm going to ask you, how do you go for the assisted bridge delivery? But Dr. Nilshat, suppose anytime this bridge can get stuck. So what we are suggesting is keep everything ready. Don't
Theatre should be ready.
The message is very clear. Whenever you, in spite of having a one full-term vaginal normal delivery, that was not a breech delivery, for make it very sure, that was a normal vaginal delivery. So even if you have such history, when you find breech at +1 or when you find breech presentation, keep everything ready. Don't take the patient for cesarean section. Then you assess whether it is coming. By the time, maybe when you are making the arrangement for cesarean section, to your surprise, you just find that the baby is thrown out. That is also very good. That is spontaneous breech vaginal delivery, right? You may not have to go for any manipulations or any maneuvers also. Correct? So spontaneous breech delivery. That is if you are lucky enough. Okay, or maybe the size of the pelvis and baby, as you said, is everything is perfect. So spontaneous. Suppose now things are fine. you have everything ready. You have
Yes.
your neonatologist and your anesthetist also ready. Suppose now this breech, it has just come up to introitus and then it is coming. It is requiring your help. So, madam, how do you go for the assisted breech delivery?
Yes, madam. Where we go with once the fetal anus is seen at the introitus, it means that it has descended very well down.
Yes.
In between contraction, if you see the anus at the level of the introitus, it says that yes, the breech has descended down very well. Now we can deliver by assisted breech delivery by giving a generous episiotomy.
Yes.
And then after once you give generous episiotomy, that first the breech is being born. If you have any difficulty in delivery, just to hook up the limbs, lower limb. After that, once the baby has gone.
I would interrupt you, Dr. Dilshad, here itself. The very fact that, the dictum here is for breech presentation, not to do lots of manipulation. Let the breech deliver up to
Yes,
at
madam.
least umbilicus.
The umbilicus, madam.
Yes, the
Up to the umbilicus.
assisted breech
No,
delivery.
ma'am, the breech will come.
After this.
Yes, the breech will come by itself, madam. If there is any difficulty, only they are going to help her. Then the baby's back should face the obstetrician.
Yeah.
Yeah. Then we have to, previously what we do cover the baby with the towel, madam, to prevent stimulus. And now you have to feel the cord. And you have to keep the cord a little away to prevent cord compression.
Right.
First you have to keep the baby with a good uterine contraction. The baby will descend, and of course there will be delivery of the shoulder, and then you can have Marshall-Burns technique by giving a suprapubic pressure.
How do you deliver the shoulders? Suppose you have the shoulders, you have the knuckle hand like this.
Yeah, madam. If there is any difficulty, we have to follow Lausach's maneuver, madam. The rationale is
what is that? What is that for the house, for the attendees?
In Lausach's maneuver, the posterior shoulder is the rationale behind this. The posterior shoulder is at a lower level than anterior. So we have to bring the one shoulder posteriorly, so it has come down and can deliver. Then you turn so that the anterior shoulder, when it come down, it also will be easily delivered.
Right.
Then after that, you have to just hang the baby for a while till the nape of the neck is visible at the introitus.
Yes.
It means it has entered into the pelvis. Now what we have to do, we have to hold the baby's feet and give a suprapubic pressure that promotes the flexion, and you have to swing the baby in an arc over the mother's abdomen. That is Marshall-Burns technique, and you have to deliver the head, madam.
What is this technique called as?
Marshall-Burns technique.
Marshall-Burns.
Marshall technique. You have to hold the ankle of the fetus, and you have to turn the baby through a long arc on the mother's
An
abdomen.
arc over the mother's abdomen at the same time giving suprapubic pressure.
Suppose still the head is not delivered, then what you go ahead?
You can go with the Morris's Maliviate technique, madam.
What is that?
What we have to do, we have to keep the baby over the forearm to support the baby's over the forearm, and you have to flex the chin.
Yeah.
Flex the chin, and you have to slide 2 fingers over the baby's shoulder. If you gentle traction, you have to, with the finger keeping over the chin, flex it, and 2 fingers which has been, the fingers which I'm sliding on either side will have traction at the same time of supporting the mother's baby's body over this. This will help to deliver. That is Morris's Maliviate technique.
Here only I will interrupt you for only one moment. You have discussed the Burns Marshall and Mauritius Maliviate technique very nicely. Only thing is posteriorly you keep 3 fingers, one on each shoulders, and the middle one on the occiput. You try and push the occiput little forward so that it helps in flexion, maintaining the flexion of the fetal head. Right. So that is Mauritius Maliviate. And then of course, if not, then
forceps, madam.
Yes. Yes. Which forceps? How do you apply for this, especially after coming head?
Pipers.
Pipers forceps. Perfect. And Madam Minambal, you want to add something?
The baby should be supported.
Yes.
And the forceps should be applied above. The handle, Pipers forceps, the handle is long. So you have to do the traction and upward. First downwards, then upwards.
Right.
And the baby will be coming out.
Yeah. So the baby should be down or up like this. How should the assistant hold the baby?
First, baby will be down. We are applying forceps. Then after delivering the thing, we have to keep above, pull it above.
Yeah. So it is
Ask
said that,
one of the assistants to hold the baby uppers with the cover
yeah,
towel.
that
Then
is
we
fine.
apply the
Otherwise, how you
forceps
can
on
apply
either
the
side
force?
and deliver the head.
Right. So that baby has to be hold little up,
Mm.
like this, and then the assistant, when the operator has to actually sit down with the forceps, the forceps are long, and you have to be, from a very closer distance, you have to apply the Piper's forceps and give it the traction as you have already mentioned. Now, only thing what I wanted to ask you, suppose now this patient, it was an emergency. Okay, she presented to you as an emergency. Suppose she was your book case, how you would have handled her? What are the deciding factors? How do you decide whether this patient should be given a trial for breech vaginal delivery
No,
or
madam.
to take her? Yes.
No, this is
Madam,
not
it's mainly size of the baby, madam. That is very, very important. What is the type of the breech? Size of the baby, type of the breech, then the whether the staircasing look. It means
Yeah,
that the head is
but then
extended.
suppose you diagnose it at 36 weeks, you find that it's a 36 to 37, you find it's a breech presentation. Then how do you counsel the patient and the relatives whether she has to be, whether she should go for vaginal delivery or cesarean section, or you have some option to, ECV, etc.
Yeah.
What is
You
your
have to tell the patient, madam, it is not a normal presentation. It is not a cephalic. It is a breech. The patient is likely to go for cesarean section at any time. Even if it is a baby, average size baby, well flexed head, and its anterior position, pelvis is okay. Even during this time, there is every possibility that patient may go for section if there is a cord prolapse or any problem they can come, or the patient may not progress normally, or a premature rupture of membrane is also quite common. All those things should be counseled with the patient.
What is that?
Patient with previous normal deliveries with average baby, we can out for vaginal delivery, madam. In a booked case. Otherwise, if she has some complicated breech, complicated by GDM or anemia or some other medical problem complicating the patient, we have to directly go for cesarean section, elective cesarean section in breech presentation.
Any other obstetric or medical indication, that is different, but breech per se, you have to consider the parity of the woman, the gestational age, that is what weeks of gestation she is presented to you as breech, and of course the estimated fetal weight, previous breech delivery, as I talked to you about, whether she has previous vaginal normal delivery or previous breech delivery. That makes a difference. And of course the dilatation and the station of the presenting part when she is presented to you. So all these, this is scored as Sattogeny Endo score, and definitely this, clinically it gives you, if it is 0 to 4, then cesarean delivery is recommended, right? If the score is very low, then of course you have to consider straightway for the cesarean section. So that is what otherwise it is recommended by RCOG, or maybe nowadays we are not going for ECV, but RCOG says at around 36 weeks, you go for external cephalic version. At least you give her a choice for external cephalic version. If at all she denies, or if there is a failure of external cephalic version, then again you give her an informed choice to make a decision for whether she wants to go for vaginal delivery or cesarean section as a planned procedure. And then of course you have to take a call. So that is what are the recommendations. So now I think this is the last case we will take. Madam Parvata Vardhini.
Yes, madam.
Yeah. So this I'm sure you're going to discuss this very well, but I think this is a case where you have second gravida with gestational diabetes. She comes to you in labor at 37 weeks. And when you examine, you find uterus is 36 weeks, cephalic presentation, the head is 3/5 palpable, fetal heart is good, cervix is 2 centimeter, fully effaced. Labor progresses very well, normally within 6 hours, she progresses very well. Now she's fully dilated, fully effaced, vertex is, seen at perineum, but there is no further progress. And the baby is not delivering. So what is your diagnosis and how do you tackle this situation?
Madam, this is a clear-cut case of fetal macrosomia with shoulder dystocia. She is an elderly mother with gestational diabetes where we anticipate fetal macrosomia and shoulder dystocia. Once the patient is admitted with labor pains, I will immediately inform the anesthetist and other senior obstetrician nurses for help, and I will alert them at the onset of the second stage. All the people should be here for help me to come over any problem in shoulder, in delivering the shoulder.
You're right. Madam, now that you have
First I will
diagnosed
call
her,
for help.
for
Then
sure. Yeah. So how do
once
you go ahead with the management?
Yeah, once the patient is not, the shoulder is not delivered, I have to bring the patient to the edge of the table. And if the patient is on oxytocin drip, immediately I will stop the oxytocin.
Right.
There's no panicky and no fundal pressure. We ask the patient not to push, and you ask her to be relaxed and take a deep breath. And I will examine and what is the level of the posterior shoulder and anterior shoulder. Because we have to do other manipulations and maneuvers to get the shoulder outside.
Okay. How do you do that, madam?
We go by this helper algorithm, madam.
Right.
First, we
Right.
ask for help. Second, I
Right.
have to give a liberal
Episiotomy.
episiotomy
Yes.
so that I can easily deliver the shoulder.
Yeah.
Then I go for this MacRoberts maneuver.
Yes.
Just I will ask the patient when she is in lithotomy position, that is changed and she thighs are flexed over her abdomen so that the
But that is just the extension beyond that. Now you hyperflex it.
Yeah, hyperflex the thighs so that the pelvic outlet diameter slightly increases. The anteroposterior diameter of the pelvis increases and the symphysis pubis will move anteriorly.
Right.
And in average babies, this movement itself will bring down the posterior shoulder so that we will be able to deliver the anterior shoulder.
Right. If
we are not able to do so, we ask one of the assistant to give suprapubic pressure. The assistant should...
Madam, I interrupt you here. Where should she give her suprapubic pressure? Whether on right side, left side? How should
on the side of the back of the baby.
Yes. So on the side
of the back of the baby, the assistant should give suprapubic pressure. She has to push the back of the baby in such a way downwards and laterally towards the opposite side so that the shoulders are adducted and the bisacromial diameter is decreased so that the shoulder will go into the pelvis easily and delivered.
Okay.
So this is
it doesn't help. Suppose this doesn't help. You are very correct. 90% of these women, they are delivered with this combined maneuver, the MacRoberts and of course the
suprapubic pressure combined. Most of the patients will deliver. So wait, if they don't deliver by this maneuver, then going for the second line maneuvers. The aim of the second line maneuvers is to either deliver the posterior shoulder or rotate the baby and deliver the posterior shoulder. These are the two steps. One is Jacquemus maneuver, in which we try to identify the posterior shoulder, go along the humerus, and we reach the elbow. We flex the elbow towards the anterior aspect of the baby, towards the chest and the face, and try to drop it out. And holding this posterior shoulder, we will try to deliver the baby. Sometimes once the posterior shoulder is out, the anterior shoulder will automatically slip from the underneath the symphysis pubis. Suppose if the anterior shoulder is still stuck up, we have to rotate the baby in such a way to the oblique diameter of one of the oblique diameter of the pelvis to reduce the bisacromial so that the baby will be delivered. So this is delivering the posterior shoulder with or without rotation in Jacquemus maneuver so that we can deliver the baby. Suppose we are not able to reach the elbow of the baby, we trace the posterior shoulder, we are not able to reach the elbow is still high up. We introduce our hand into the hollow sacrum, we try to reach the elbow, not able to reach the elbow means we use our finger or some rubber tubing into the axillary fold and give traction on the posterior shoulder. Then we deliver anterior shoulder with or without rotation of the baby's back accordingly.
Okay. So what message you want to give for this case? During
Anticipate.
emergency, yes, during this emergency, what message, what are the do's and don'ts for this?
As per
We have to get the IV line, we have to get the blood ready, we have already catheterized the bladder, bladder is empty. In these
Don't
manuals,
for the obstetrician,
the baby
apart
is
from the
likely to
routine
be
management.
injured. The injury of the brachial plexus, fraction of the clavicle, fraction of the humerus, baby is likely to go in for asphyxia, and lacerations and injury to the porcine canal of the mother. And extremely, the rupture uterus can occur in the mother because we are manipulating the baby for quite a long time. We try to deliver the baby, and in our anxiety, we're doing a lot of maneuvers. So this will end in severe morbidity to the baby as well as morbidity to the mother also.
Yes. So definitely, first and foremost, don't become panic. Stay cool with your brain, but stay active with the body. Do the movements fast. Not to give excessive traction, not to give any traction for that matter on the head or neck of the baby. And of course, no fundal pressure, right? These are the don'ts for this patient. And definitely what you have to do is you have to do the various maneuvers to deliver the baby. So I think this is just a partogram which actually I thought we will discuss. So I think we will conclude our panel discussion here. Yes, Madam Lalita and Minambal, anybody wants to add anything? I would just conclude by saying that we have to anticipate all these findings, because now we have so many facilities, the gadgets, so anticipation, keeping a high index of suspicion. Whenever you are doing something or you are managing some patient, skilled supervision, vigilant monitoring of that particular case, and prompt or earliest detection and timely and appropriate intervention should, prevent disastrous consequences. Of course, not to forget the communication with the patient, with the relatives, with empathy and documentation of whatever you are doing. From time to time, you have to explain to the patient and relatives and maintain your documents well. So I think with this, I thank all of you for your, active participation, and I humbly appeal to all the societies of Tamil Nadu Federation.
Thank you, thank you.
Thank you so much, Madam. Moderate Society, we thank you.
Thank you so much, Madam.
So I just
excellent panel, Sneha.
Thank you, Madam. Thank you,
participants also.
So I thank all the societies, President, Secretary. I thank all the members as well, and I thank the excellent panelists for the very interactive discussion. I thank Dr. Kalpana and Priya for this, wonderful coordination.
Lovely panel, Madam. Very informative. Every case was so interesting. And it was like, dealt in such a great detail.
Yeah, thank you so
like everybody who has been there in the panel would have definitely benefited.
Last but not least, I just make an humble appeal to all of you to support me for my candidature as Foxy Vice President from West Zone. The elections are coming soon in August. So I request your wholehearted support and see to it that all of you vote for me as first choice. Thank you.
Ma'am, advance congratulations.
Thank you so much, Madam. Thank you so much, all of you. And I think, do we have anybody here to make any comments? So, Madam.
Thank you, and excellent panels. We don't have any other comments, Madam. No,
thank you. Thank you so much. Over to you, Priya. Thank you so much. I take this opportunity to thank you.